Good morning, ladies and gentlemen. We reconvene our meeting of Joint Labor, Health, and Social Services. I have a couple members that are excused for a later arrival. So I think that we do have everyone that we expect present with a couple of excusals, and we'll get started with the business. First, Chairman Scott, with the microphone, please. We are streaming live, folks, so remember those that weren't here yesterday. Remind folks that weren't here yesterday and those that are here that if you use the microphone, the folks that are listening over the World Wide Web and whatever other options there are, they can hear what's taking place in our meeting. So thank you.
Mr. Chairman, inquiry for the Legislative Service Office staff. I'm always concerned if we get too many committee bills. How many committee bills do we have at this point?
As they're doing a little tallying up, the first bill, of course, our first order of business on the agenda is our Opioid Addiction Task Force. So folks that are interested in providing public testimony on that, the bill was before us at our last meeting, so we won't be actually walking through the bill, but we certainly take any public testimony on the bill in its current form, and then we will proceed to work the bill. So that's what will be order of our business. Let me get started. I think what Chairman Scott's getting to is if we reached our limit, we're just going to cancel the rest of the day. Is that?
I don't
I apologize.
think, Mr. Chairman, we can exactly do that, but each bill, even a very simple one, takes a fair amount of time and committee time, and I'm wondering where we are in the process.
From last time? Mr. Chairman, 9.
9, that's that we have approved and voted to introduce so far. Okay, so we're all right so far.
Yeah. Perfect.
Thank you. Thank you, Mr. Chairman.
Thank you, Chairman Scott. So we will proceed with the item and agenda number, I guess it's 10, as we're in the second day. Opioid Addiction Task Force. We have LSO 157 version 2, Controlled Substance Act. And I think we're just going to start off, since this is a bill we saw last time, as I mentioned earlier, we start off with public comment. So does anybody would like to provide public comment on the Controlled Substance Act bill? Any public comment? Public comment? Please, please, Mr. Odikoven. So let's clarify that. Thank you, Mr. Odikoven. So Ian, so on the agenda it's listed as point 1 on point 2, and on what's available is point 1. So let's make sure that the public has available what they would anticipate, because we in our materials have point 2. So let's find out what level of difference there is between the two. Okay, thank you very much. Who needs a copy of point 2 before we go make 100 copies? Just a half a dozen, Jill. Just a half a dozen. So committee, just so we're on the same page, does everybody have a copy of point 2 in front of them? Ian, is there another copy of point 2 for Senator Pappas? Okay, we'll get more. Okay. All right, I'm still going to start with public comment while we're waiting on those copies to be made. So any public comment folks would like to make on the controlled substance bill, which is going to be currently 157? Public comment on that bill. Public comment on the bill.
Mr. Chairman.
Senator Scott.
If there's no public comment, I've got a question.
Fire away, Senator Scott.
The question I've got is I know in other states, this kind of registry where you can find out what's prescriptions have been available. They have aggravated them by prescriber. And that information has been useful to elsewhere to licensing boards and I believe law enforcement on finding outliers who are prescribing a lot more opioids than you would expect. And sometimes that's led to identification of somebody who's just being careless about what they're doing. And sometimes it's led to identification of somebody who's been basically selling the drugs into the black market. Is the system that's referred to in here, is that available for that purpose?
I think we have some representatives from the Board of Pharmacy, so please come forward. Pull the mic close, make sure it's on, and please introduce yourself and proceed. Go ahead and pull it closer to you, Ms. Hunt. Thank you.
Mr. Chairman, members of the committee, my name is Lisa Hunt. I am the Executive Director of the Board of Pharmacy. And in anticipation of this morning's meeting, I did bring some show and tell handouts. May I provide those to the committee members?
Please do.
I brought enough for audience members too as well. The Wyoming Board of Pharmacy currently administers the Wyoming Online Prescription Drug Database. And the report that you were talking about has been called a practitioner report that shows practitioners where they stand in relation to other prescribers and or dispensers. Practitioners will have areas of specialty, so it can be drilled down, or the data can be mined to show exactly your area of specialty and where you fall. Now, whether or not you're prescribing more because you see more patients, or the patients you see have more serious diagnoses, that is something that is often left up to the practitioner to decipher themselves. In some states, this information is then passed on to the regulatory boards. Right now, our regulatory boards can ask for practitioner reports, and we provide them. If we find anything of concern with our current system, where we look at people who go to multiple different prescribers and multiple different pharmacies, we do refer those to the appropriate agencies, as we are obligated to by statute. The handout that I passed out shows the effect. In 2017, the Opioid Task Force worked with, and many of the legislators worked on the bill to require registration into the prescription drug monitoring program. You can see that we've had a significant number of new registrants beginning in early 2017. What is nice to see is on page 2, we've had a significant increase in the number of people who search the database. So, and that, of course, is our ultimate goal, is to get more people using the tools that we have in place. So more searches are currently being done. And the top one is number of searches by registered user. The second graph on page 2 is the total number of registered users, again, showing that going up. And then the next page shows the number of registrations or registrants by license types. We got very creative in the colors that we had to choose because we have so many different license types. And then the last one shows the number of registrants that we currently have. Practitioners in state now is the largest group. So with that, I stand for questions.
Thank you very much, Ms. Hunt. Senator Scott, did that assist with your inquiry?
That answers I've got another question once appropriate, Mr. Chairman.
Go ahead and proceed, Senator Scott.
Mr. Chairman, on page 11.
Now we're on the bill, version 2.
On the bill, version 2. Page 11, line 21. and really that whole paragraph, we're talking about Medicaid. And my question is regard to the last phrase there, and shall not be used to conduct non-individualized data matching queries. What's that all about, and why are we doing it?
Ms. Hunt.
Senator, or Mr. Chairman, Senator Scott, the that part, I believe, was in response to a desire by the Department of Health to have access to the prescription drug monitoring program and to be able to get reports. I myself am not sure about what the actual language is. I do believe there were some concerns that were brought up about is this going to open or lead to, I know some of my board members have asked me, will this lead to then other third-party payers having access to this data? Will they now want to have access to this data? Is this for an individual patient per an individual case and an individual need, or is this something that they might get into the database and start, looking at everybody, I mean, part of the statute does say that we're not supposed to interfere with the legitimate prescribing of a controlled substance. So I have been asked those questions by my board members, so I can share that with you.
Thank you. So we do have folks who represent the Department of Health and Wyoming Medicaid office. And so this, to be clear, this is a product of the Opioid Task Force, and Senator Baldwin was on it. So maybe Senator Baldwin, if you want to maybe give some insight to that, and Representative Clem was also on that. Start with Senator Baldwin.
Thank you, Mr. Chairman. The final sentence of that paragraph talking about shall not be used to conduct non-individualized data matching queries was to prevent people from getting onto that, or specifically Medicaid or anyone getting onto that and doing just a randomized search and coming up with people that aren't involved in that particular investigation. That was a concern, that they would get information that didn't concern that individual patient. That involved any one of number of people who got a narcotic prescription or a controlled substance prescription. This narrowed it down to where they can only get the information on that patient on those specific things. And that was the purpose for that part of it, I believe.
Senator Scott.
Mr. Chairman, and is the basic concern a privacy issue? What led to the restriction?
Senator Baldwin.
Thank you, Mr. Chairman. I believe the concern was that it may be a HIPAA violation, actually. We may be looking at things that we have no business looking at, or the Medicaid would be looking at things, and this was to prevent that.
Representative Clem, anything to add? Thank you. And just to maybe round out that, is there any other questions on that particular part of the said? Representative Halverson.
Thank you, Mr. Chairman. We have an amendment coming up that would strike that whole paragraph. Not only could this be a HIPAA violation, but we're going to try to make the case that it's a violation of the United States Constitution.
Okay, thank
Amendment
you.
5.
Further discussion of this particular piece. So at this point, I guess I would invite, if the Department of Health, and they're all sitting back quietly saying, no, we're not part of the Department of Health. If anybody wants to make a comment on this, come on up, Dr. Bush. You don't have to run away, Ms. Hunt. Please.
Thank
Go
you,
ahead.
Mr. Chairman. My name is Dr. James Bush. I am the Medicaid Medical Director for the state of Wyoming. And that language actually came in because of the actions of our Home and Community-Based Services Waivers Quality Assurance Committee. In that meeting, we are reviewing critical incidents, critical cases, cases of abuse, neglect, exploitation, etc. We are only, and the access to the PDMP, prescription drug monitoring database, is very important for that. That's why we limit it down to very specific patients. These are only Medicaid patients. There's no HIPAA violation because we are the ones paying for those services, and this is directly related to the quality of care. We have had cases where they are at risk for death. We've seen several cases where there was death. we've seen diversions of drugs, et cetera. So that's why, and we crafted the very specific language so there would not be any potential for a HIPAA violation, any violation of rights. This is all data we are actually entitled to. The only trouble we have is we can only see what Medicaid is paying for. We cannot see if there are drugs that are being paid for, by cash, et cetera. So at the moment we are, working cooperatively with the Board of Pharmacy, but we are only asking for access for this only on our Medicaid clients. So I'll be happy to answer any questions regarding this.
I just want to clarify a couple of things. So actually the language reads patients, practitioners, pharmacists, and pharmacies. So it's not just about individual Medicaid patients. So I just want to be clear that you recognize the language is broader than individuals. The second thing is when you speak about death and diversion, those seems like they'd be law enforcement issues. So have there been charges brought and law enforcement involved in these cases? I mean, it's a pretty serious thing that you're saying.
Several of
I
our
don't want to leave anything untouched here.
When we do find episodes of those, we do refer to the appropriate agencies. We have referred several cases to the Drug Enforcement Agency, the DEA, and that has resulted in loss of license.
All right, thank you. Representative, questions from the committee on Dr. Bush's? Representative Clem.
Yeah, thank you, Mr. Chairman. Dr. Bush, thank you for that. Yeah, this is one of the most hotly contested, or one of the pieces that was hotly contested when we had this. And I'm still, even now, I'm still trying to piece together why this information is pertinent to Medicaid. The argument was made, well, if we open the door for Medicaid, then Blue Cross Blue Shield might be entitled to information because they're a payer too. And we get down this rabbit hole that's never ending. Help me understand, just you said something as far as, I realize if Medicaid is paying for something, we can see that right away. And I just want to be clear that what you're talking about is that if a person acquires a prescription but chooses not, goes to the pharmacy and has it filled, they do the inquiry into the PDMP as they're supposed to, and then let's say they don't use Medicaid to pay for it, they pay for it out of pocket. So those are the types of things that you are looking for. You're not looking for what Medicaid is paying because you can obviously see that. You're looking for what they're paying for out of pocket, trying to, maybe they don't want Medicaid to pay for it or something. Is that kind of on the, am I on the right track there?
Yes, sir.
Okay, thank you. Further questions for Dr. Bush? Further questions? All right, thank you, Dr. Bush.
Thank you.
All right, anything, any other further questions for anyone on the bill? I made Ms. Hunt stay at the table, so please ask her a question. Representative Clem.
Thank you. Ms. Hunt, just along those same lines. So I think this provision of the bill was put in particular to try to, I mean, when we're talking about this opioid epidemic and we're trying to save lives here, that's the whole point of this. And so I understand from the Department of Health standpoint that, hey, we want to know this information on Medicaid patients. However, if there was some kind of red flag, for instance, if you're working at a pharmacy and you went ahead and you did an inquiry of the PDMP and you found that, oh, we've got multiple opioid prescriptions and now they're trying to pay for this one out of pocket because maybe Medicaid won't. That would raise a red flag for you, in which case I'm assuming you would do something. Medicaid, they don't even have to know the information. You yourself, as kind of the first line of defense, would do something. What is it that you would do?
Mr. Chairman, members of the committee, Representative Clem. Yes, well, we ourselves do not get a report back automatically. It's when the pharmacist picks up the phone and calls us. We get a lot of phone calls from pharmacists who have had red flags. We've also gotten calls from practitioners who are upset that pharmacists have refused to fill their prescriptions or put other qualifications on it, like I need to know this is for a legitimate medical purpose, that type of thing. And pharmacists do that because they have a corresponding responsibility that the prescription is filled for a legitimate medical purpose, but they don't have a diagnosis. So one of the ways that they get around that is through policies that are put in place to help assure that it is a legitimate prescription. So when we get that call, we open an investigation and then we run the report and we refer to the agencies, the appropriate agencies, whether we refer to the DEA, we refer to DCI, and we refer to the licensing board if we think there may be some concern. Of course, the other licensing boards are the experts on their practice act and their standard of care. And then it is left to them to review their case and make their determination.
Representative Clem.
Mr. Chairman, and just to follow up on that, so if we were to remove this provision of the bill, giving information to Medicaid, I think my point is, and I hope that you would agree, that we are still responding, that pharmacists are still going to respond, and that we are still going to be taking action, that this is not going to hurt or kill the bill necessarily. We could go without it. And we're still going to be able to do some things. Is that correct?
Mr. Chairman. Mr. Chairman, committee members, Representative Clem, yes, that is correct. We will continue to do our job as we're obligated to do under this statute. In addition to that, anybody can register a complaint. We have had parents, we have had the Department of Health has contacted us, and we've opened investigations and run the reports. And then we, at the end of our investigation, and we certainly refer to the appropriate licensing boards and agencies. And then at the end of that process, we do report back to the Department of Health whether or not the case was closed or whether or not it was referred.
Mr. Chairman.
Senator Scott.
Chairman, do you ever get inquiries from mental health practitioners that are dealing with somebody they suspect has a real substance abuse problem?
Ms. Hunt.
And they use that database?
Mr. Chairman, Senator Scott, we get complaints from all types. They do not have access to the actual report themselves. The report is considered confidential. So the mental health practitioners, if they register a complaint with us, we do our investigation, and then we refer to the appropriate agencies. They don't get the actual report.
So Ms. Hunt, maybe we should put a little context. How many in a month or a year, whatever time frame, just give me an estimate of how many complaints you get and how many subsequent investigations and how many subsequent referrals, please.
Mr. Chairman.
And they can be rough numbers. I'm not giving you much time, but.
Mr. Chairman, members of the committee, nobody likes to report about complaints, but yes, we get complaints. They are not, sometimes they're about prices, which is not outside of our authority. Oftentimes we get complaints on customer service, again, outside of our authority. But we get around 80, we end up opening about 81 investigations a year. And not all of them are related to controlled substances.
Thank you. Further questions for Ms. Hunt? Senator Bouchard.
Thank you, Mr. Chairman. I'm not specifically on this section, so
we're asking questions on the entire bill.
So my question is when someone looks in the system and they're getting ready to prescribe a class 2 or higher, what can they see in the system? Can they see under class 2 and regular as well?
Ms. Hunt.
Mr. Chairman, members of the committee, Senator Bouchard, yes, they can. The legislation that was put in place in 2017 actually broadened it from C2 through C4 to C2 through C5. The different schedules are the level of potential addiction and or abuse, so C2 being the highest.
Okay.
Follow up, Senator Bouchard.
Thanks, Mr. Chairman. Yeah, because I'm concerned with the cocktail situation that happens. I mean, they're taking another drug, maybe not a narcotic, but it reacts. So I just want to make sure we are covering that scenario.
Further questions for Ms. Hunt on the bill?
Mr. Chairman, can I add a follow-up? Yes, Mr. Chairman, members of the committee, Senator Bouchard. The interaction is an interesting point that you bring up. The board also has the authority to put non-controlled substances in the tracking program. They've added muscle relaxants, some muscle relaxants. They've added other drugs of potential concern, the gabapentins, but not all drugs that can interact. I believe that part of the intent is for practitioners to be able to look into that database to see if there is a drug that's currently prescribed that the patient may not have told them about that may interact even with a non-prescription drug product. I mean, a non-controlled prescription drug product.
Okay, thank you, Ms. Hunt. Senator Bouchard.
Thanks, Mr. Chairman. You know, this is one of the concerns, because what I see happening are these other drugs that are causing some deaths, and then it's getting blamed on the opioid. So do we need to put language in here to broaden that a little bit and give you more authority to actually, I mean, I want to make sure we catch it all. I don't want to just do this half-assed here. So that's my comment.
Partial buttock. We'll go with that. Would you go ahead and respond to that?
Mr. Chairman, members of the committee, Senator Bouchard, the board does have the authority to add additional drugs. The prescription drug monitoring program, it is not a complete electronic medical record with all products prescribed. Some states have gone to that point. It is very complicated and it tends to be rather costly. I don't have figures with me today. And you know, it's a much bigger project than what we have right now.
Let's go with Representative Clem.
Thank you, Mr. Chairman. And just to Senator Bouchard's point, that's exactly one of the things that we were looking at on the opioid addiction task force. The interaction, we know that there's many deaths caused when you mix anti-anxiety medications, for instance, with opioids, that leads to death. And so, yeah, that's precisely what we are looking at, so that we could catch not only people who are abusing or trying to skirt the system when it comes to opioid prescriptions, but also what are they taking them with that could lead to premature death. And so, which is to that point, one of the reasons why we talked about continuing education for doctors to realize that it's not just opioids that you need to be worried about. It's the interactions with these class of drugs with other drugs and how they interplay. And so for providers to be aware of that. So.
Thank you. Senator Scott.
Following up on that whole line of questioning, what prescriptions get into this? I understand a Wyoming doctor writes a prescriptions filled in Wyoming. That is in the database. Wyoming doctor writes a prescription and it gets filled online. Anywhere else in the country, is that in? If somebody gets a prescription from someplace like Canada because it's cheaper, I gather that probably doesn't make it. What's in and what isn't that way?
Ms. Hunt.
Mr. Chairman, members of the committee, Senator Scott, we currently have a draft contract that's we're working with the AG's office for the final dotting the I's and crossing the T's that will connect us to interstate data sharing with the other states that have prescription drug monitoring programs. In addition, it will add delegate accounts so that as a practitioner prepares for their day, they can have somebody who's appointed as their delegate run the reports for them and have them waiting for them for their review. There are approximately 48 states currently that are signed up with interstate data sharing, and Canada is not one of the countries that has elected to participate in that at this point in time.
Senator Scott.
Mr. Chairman, I did not understand the answer.
Oh,
what's in and what isn't?
Ms. Hunt.
Mr. Chairman, Senator Scott, do you mean what drugs specifically?
What are you getting, Mr. Chairman? Are you getting information on what prescriptions? If a Wyoming doctor prescribes and it's filled in some other state, because a lot of these drug benefit programs make efforts to get your prescription filled mail order. Do those get in or do they not currently?
Ms. Hunt.
Mr. Chairman, Senator Scott, we're hoping within right about March, we should be getting that information, and practitioners can query the other states' databases. That is what I was referring to as interstate data sharing. We will be able to share data from the other programs.
So currently, no.
Currently,
Soon
no.
to, coming soon.
Yes.
Senator Bouchard.
Thank you, Mr. Chair. I want to go back because I think there's maybe some misconceptions. So the scenario I was talking about is when someone may be getting therapy for another ailment, and yet so the doctor or psychiatrist maybe has given them an antidepressant or something, and now we've got a doctor that's treating them for something else, maybe a break. So now they can't look at what the other one is doing. So maybe is there a way that we could take those other drugs that we know that could be a problem, that when they make a cocktail, could we classify those as another drug that has to be in the system, so that way doctor over here gets to look in that system? And that's what my concern is, because it looks like there's a high percentage that just get missed in this whole thing, that they get prescribed this other drug, and by the time they figure this out, the person's dead, and it's attributing to this number on the opioid deaths. So that's what I'm trying to figure out. If there's a way we could maybe simply do that now, rather than find out later on.
Ms. Hunt.
Mr. Chairman, members of the committee, Senator Bouchard, I believe that was the intent when the legislation was originally put in, that allowed the board to put non-controlled prescription drugs and require those to be reported. The board has put some of those drugs on to be reported. The problem that we're going to get into is that when we share with other states, those states may not require dispensers and practitioners in their state to report those drugs. So it will not be a perfect system that will always have exactly what we want when it comes from another state.
Thank you.
Yeah.
Representative Halverson.
Thank you, Mr. Chairman. Boy, the mention of mail order really triggered something for me. The Department of Workforce Services, Workers' Comp, requires mail order. I know this because my pharmacist is always complaining to me about that. So have you opened a dialogue with them about seeing what the two of you can do together?
Ms. Hunt.
Mr. Chairman, Representative Halverson, even pharmacies that ship into our state are required to be licensed. We refer to them as non-resident pharmacists, and they are required to also report into our prescription drug monitoring program.
Assure your pharmacist it's. All right. Any further questions on this bill? So I have a couple questions. On page 8, we talk about requiring, page 8 and 9, which you don't have to look at the bill. It just talks about requiring the electronic prescription and a date certain, which is 2022. Would you talk about, I think I've understood that the federal government through Medicare and Medicaid is requiring electronic prescriptions sooner than that. Are you familiar with that? And would you just remind the committee about that, please?
Representative Barlow, members of the committee, my understanding is that it will be required by 2021. So a little bit earlier than what we have in this bill.
And to be clear, that's not just for controlled substances, and I know this is maybe beyond what you want to, if you don't want to testify to it, this is for all prescriptions that would be eligible for Medicare or Medicaid or subsequent to that. Is that correct?
Not only, I can't attest to that specifically.
Thank you. Representative Clem.
No, Mr. Chairman, I just wanted to make sure we got that date. It's in 2021, but is there, what's the calendar date for that so that we could reflect that on the bill?
Mr. Chairman.
Go ahead, Ms. Hunt.
Members of the committee, Representative Clem, I will get that date to you.
All right. Any more questions that Ms. Hunt might be able to assist with immediately on this bill draft? All right. Thanks, Ms. Hunt. Representative Sweeney.
Thank you, Mr. Chairman. A question to the bill draft. it, if I remember correctly, the meeting in Casper, Representative Clem, I put forth an amendment, and it was, I believe, a little more restrictive as to it. It was more, I think, if somebody called to get help for an overdose situation, this is my recollection, and that it could be construed, and I've had some therapists and addiction folks in Casper come up to me and say, would this prohibit people on the street that saw an overdose at a house party, let's say, and from calling for help, because they then would be charged with a felony. And I don't think that was the intent, but I can't remember if it went through.
So Representative Sweeney, I think we're referring to a little different bill, because we did pass two other
Was it?
bills here. It wasn't this particular bill
Okay.
that you're
Okay.
referring to, and your memory is accurate. There was that discussion, but it wasn't a particular respect to this bill.
Okay.
All right, further discussion from Ms. Hunt, further questions from Ms. Hunt. Thank you, Ms. Hunt. We appreciate you being here and the information. Anyone else want to provide public testimony on this bill? Anyone else want to provide public testimony on the bill? Going once? Going once. Come on up.
Mr. Chairman, I am Melinda Carroll, pharmacist. I'm currently practicing, and I am also on the opioid task force. In regards to this bill on, again, looking at prescriptions that were mailed in, yes, I can see that in regards to any prescriptions that were filled mail order that came to a Wyoming patient. If that same patient decided to take their prescription and go fill it in Colorado, no, I cannot currently see the prescription that was filled in Colorado. As Lisa was stating, that should be able to occur soon. And I am open to clarify anything else in regards to the PDMP, the medications, intent of the bill.
So thank you, Ms. Carroll. So you believe with the interstate type agreement that's maybe goes live in early next year, that is adequate to address the concern that you're just speaking of?
Mr. Chairman, yes, it is. Because we are a bordering town, that is a concern for pharmacists when we search the PDMP. If they are filling prescriptions in Colorado, Nebraska, things like that, we would not be able to see it at this time. Going forward, we will be able to see those prescriptions. That is only if they probably fill for cash. If they are filling under their insurance in both locations, I would be able to identify that they had something filled.
Okay, thank you. Any questions, further questions from Ms. Carroll? Further questions? Thank you very much. Thank you for your work on the Opioid Addiction Task Force. Appreciate that. Further public comment, going once and twice. Staff is approaching. Okay, it's not for me. Going three times. All right, thank you. Senator Scott.
Move the bill.
There's a motion and a second to advance LSO draft 157 version .2. That was Senator Baldwin. Senator Scott, Senator Baldwin. All right, committee, I know I've already heard about a couple amendments, so I'm just going to start at the beginning of the bill, walk through the bill. We get to the end. Certainly you can pontificate on while you're making your amendment specific to the amendment, and then we'll have a general discussion on the bill at the end. All right, so let's start page 1, 2, page 3. I'm going to make just a comment about the CE requirements, and I thank Ms. Hunt for some suggestions that she made. I was trying to find a more streamlined way than to go in all these different practice acts to require CE. And it got a little bit wonky, at least my reading of it got a little wonky, having the Board of Pharmacy doing it, and maybe been a little excessive for their, at least at this point, for their ability to track CE. So I decided to leave it alone. I may revisit it when the session comes, but at this point, I'm just going to leave it alone and let the, as this section goes through all the different licensure boards, responsible licensure boards, and leave that in their hands. So page 4, page 5, page 6, page 7, page 8. Representative Clem.
Thank you, Mr. Chairman. We did get that date from LSO, so I would make the motion to, it's in several places. So on page 8, line 8, line 19, and line 21, where it gives the date of January 1st, 2022, to change that to January 1st, 2021.
So the motion, I'm just going to make sure everybody's clear, will be, thank you, there's a second from Representative Halverson. So we're changing basically all the 2022s to 2021 on page 8, and I see 3 on page 8. And if there's subsequently anywhere else in the bill that's referring to the same topic, we'll take those up too. But I see at least 3 there. Discussion on that amendment. Discussion on the amendment. All those in favor of the amendment, please signify by saying aye.
Aye.
Those opposed, no. Motion carries. Further amendments on page 8. Page 9. Senator Baldwin.
Thank you, Mr. Chairman. I would propose, it's in more places than one on page 9, on line 7, line 14. I would propose an amendment that we remove the exemption for veterinarians from the bill and put them back in. After hearing a lot of testimony, a lot of discussion with veterinarians, I would propose that we remove those exemptions and put those back in.
So I'm just going to make sure we're clear. The amendment would be to strike, just as an example, on line 7, strike comma, other than veterinarian, comma. And that is repeated on line 14. And if it's elsewhere in the bill, it'll be repealed there too. So there's your motion. Do I have a second? Second. There's a second, I believe, Halverson. Second on the motion. Discussion on the motion. Senator Boner first.
Well, Mr. I just need a little bit more explanation. I've heard from constituents of mine who are veterinarians who certainly would not want this exemption to be removed. So I'm going to need a little bit more discussion than what we've heard so far.
Okay. Representative Clem.
Thank you, Mr. Chairman. Yeah, another one of those, what to do. I'm going to be opposed to this amendment with all due respect to my colleague. One of the things that we need to consider here is when we're talking about reporting into the PDMP for veterinarians are a little bit different in the fact that not all of them work out of an office. Many of them, if they're out in the rural part of the country, may not even have access to a computer. And if they're dispensing or prescribing some of these medications, and then they're supposed to query the PDMP, it really puts them again in a precarious situation. And so that was the hang up for me is it's not the clinic that you see in town or anything. And many of them do it. My wife watches a child of a veterinarian, and I often talk to her about what their policies are, and they query the PDMP. But you get someone who's a veterinarian on their own, working out in the country, they're not going to query the PDMP. And by removing this with this amendment, you would require them to query the PDMP and be a part of that system. And so I think it just gets a little bit tricky with the rural nature of Wyoming.
Representative Halverson.
Thank you, Mr. Chairman.
On the amendment.
Yes, on the amendment. On the other hand, those clinics in town, by exempting veterinarians, will be the go-to dispenser. As soon as we exempt veterinarians from having to query or report, that's where the folks, the seekers, are going to go. And I had a dog that had a leg amputated, and they prescribed some pretty powerful drugs for the dog. The dog got all the medicine, I assure you, but it could conceivably become a valuable commodity that I go out and market to my neighbors. I support removing the exemption.
Further discussion on the amendment. Further discussion on the amendment.
Chairman.
Senator Scott.
Mr. Chairman, I would ask the chairman, what are the implications of this for the practicing veterinarian?
So for the Senator Scott and for the committee, I actually support the removal of the exemption, and I do so for three reasons. One is that within the current statute, and this was added in the last session, there is the board the ability to grant reasonable time extensions to a dispenser or practitioner who is unable to file electronically or search information as required. So the board already has some latitude in timeline. Now, I think that could be expanded a little bit for type of inquiry, et cetera. I think you could go a little further. The second reason I'm going to support this amendment is that unlike many other of the practitioners, veterinarians prescribe and dispense. So they actually have possession of the drugs, not just a notepad that they hand somebody a notepad and they go somewhere. So, and I don't know, and I certainly I'm going to get myself in some trouble with some of my colleagues, but I think I think that they are actually in a more unique spot than many other practitioners because they both have the narcotics in their possession and they are prescribing. So I think they're actually, there's actually another, even different level of responsibility, maybe a higher level of responsibility in that sense. The third reason is that we're talking about everything at the state level, and I do not no longer have a controlled substance license because I do not utilize any controlled substances in my practice. But they also have an obligation to the Drug Enforcement Agency, and I don't think that the state, even if we added some language later and as we work the bill that said you have to do something at least as similar, or at least record keeping as similar as the drug enforcement or other federal agencies would require, is inappropriate, and report at some timeline. So, I guess I'm supportive of this. I understand there's some logistical issues with technology and distance and everything, but I think there's some other factors that make veterinarians a little more unique and a little more susceptible to access being a little broader. And let's be clear, when we talk about those mobile practices, that's a truck out in the middle of the countryside. Where those narcotics or those drugs would be available in that setting. So I'm going to support this amendment. I think maybe we could do something down in the reporting apparatus. I don't have the language to do it today, but I will bring that if this bill moves forward and goes to the session. So I don't know if that answers adequately the question, but that's my thoughts.
Chairman.
Senator Scott.
Follow-up. To what extent does the large animal vet practicing out in the country actually use and need to use these opioid medicines?
Thank you, Senator Scott. I would say that it depends on the type of large animal. So if you're an equine practitioner, you would have a different level of need than a food or fiber type practitioner, which is why I don't use them anymore, because I primarily do food animal type practice. But I think they will generally have it. The second thing I would say is most veterinarians that are in country practice or mobile type practice still take rabies shots, still do some things out in the country that may require, I'm not saying a rabies shot requires sedation, but they may do other things while they're on a country call that may require some sedation, would have some agents with them. So I would say that, Yeah, I don't think any type of practitioner should be exempt from this, nor any subtype of practitioner should be exempt from reporting and keeping track of this would be, I think, what you're getting to. Thank you. Representative Sweeney and then Halverson. Representative Sweeney.
Thank you, Mr. Chairman. So if this moves through and you have a mobile veterinarian out in the middle of nowhere treating an animal, are they totally in the wrong if this amendment goes through? Or back to your point on some of the reporting requirements at a later at the beginning of the session, that can be adjusted, and also to the Board of Veterinarian, that can also be adjusted to become more broader so that the veterinarian isn't in trouble.
Representative Sweeney, if the question is directed direct to me, I would say I think there is some adjustment that still could be made within the bill. I do not have language that is probably ready to do that, but I do strongly feel that the exemption for veterinarians is not appropriate, and we can, if it's timing or whatever, we can address that in a different way. Representative Halverson.
Thank you, Mr. Chairman. A note to our state executives who are implementing and monitoring these programs, maybe a mobile app is not far off into the future.
Blockchain. Thank you, Representative Halverson. Senator Boner.
Thank you, Mr. Chairman. Just a technical question. And when it says you're tracking based off the patient, how does that apply to a veterinarian? Are we talking about animals? Are we talking about the humans? I mean, I'm not sure if nothing else from a technical standpoint that this amendment would work until we answer that question. I mean, the point is to prevent humans from abusing it. So I think we have to answer that question. When we have that requirement in the statute, who exactly is the patient?
Ms. Hunt, do you want to respond to that? Or provide context to that? Thank you.
Mr. Chairman, members of the committee, sorry I missed who asked the question. So
Senator Boner, but go ahead.
Senator Boner. Currently, right now, pharmacies do report into us when they dispense prescriptions for animals. They have the software programs that pharmacists use have an area for that information to be reported in. Our currently proposed draft rules includes reporting the species in with the medication. So you would have perhaps you would have like the last name. So using myself as an example, it would be Hunt, the pet's name, Nigel, my German Shepherd, and then species would be canine or dog, and then you would have the medication. So the system currently has the capability of capturing that information.
Senator Boner.
Thank you, Mr. Chairman. I guess my point is, I mean, even if we do require veterinarians to report during the system, I mean, if somebody's going to abuse it, all of a sudden they have 20 dogs that need opioids, are we really accomplishing what we're setting out to do, or do we have to maybe give a little bit more thought to this?
Further discussion? Senator Bouchard.
Thank you, Mr. Chairman. I originally I would have been with Senator Boner on this, but I just did a search, and this article says Colorado vets suspect some pet owners of abusing animals to get opioids, and it shows different stories on here. One woman cut her golden retriever with razor blades so she could get the dog's pain medication. Another one here, an Ohio man taught his dog to cough on command in order to get prescriptions for cough syrup. And it goes on. There's just, so it's apparently, so anyway, I'll leave it at that.
Thank you, Senator Bouchard. And I want to respond a little bit to Senator Boner and potentially Representative Clem, the concern about whether it's the patient or the patient's owner. And that can be, we can clear that up with amendments. We can clear that through board rule when it comes to that. I think the point being, if you've got 20 dogs, which I do have nearly 20 dogs, and I've got 20 dogs in the prescription system and they're all getting a opioid, there's probably a problem there. And so, you know, we can have these, you know, I think it's a red herring to say there is a responsible party for that animal. And that is the person that receives the prescription, is who receives the narcotic. And that's the person that we're trying to get to. We're not, the dog isn't out saying, hey, buddy, you want one of mine? I'll trade you. It's the individual. So I think that's what we're trying to get to. We're trying to get those, whether it's diversions or, you know, people discontinue use. Pretty common in the veterinary world. You get a prescription for 7 days of whatever it is. 3 days in, the dog, you want the dog to slow down, not speed up. So you say, well, I want him to feel a little more. So you take some clients may take away the pain relief and withhold. And obviously they're in control of that, not the companion animal in particular is where you would see this most. All right. Further discussion on this amendment, So the amendment again, ladies and gentlemen, is to strike comma other than a veterinarian comma as it is placed throughout the bill. Further discussion, seeing none. All those in favor of the amendment signify by saying aye.
Aye.
Those opposed, no. Raise the hands. All those in favor, raise your hand. Okay, motion carries. Right? Actually, re-raise your hands, please. I'm sorry. All those in favor? 6, 7, 8, 9. Okay. So motion carries. All those opposed, just to make them feel like they got their say. All right. Thank you. Motion carries. Further amendments on page 9. And just to be clear on that note, I will bring some better language for the veterinarian issue. And any other practitioner this may reply to. Page 9, page 10. I'm going to suggest a motion on page 10, line 6. And this has to do with the language consultation versus concurrence. And I guess my experience in rulemaking is there are very few, it can be rather challenging when two authorities have to agree on the same thing. And I'm just going to give you an example that's a little different, but this has to do with the Livestock Board and the Game and Fish Commission on what a wild bison is and where a wild bison roams in the western side of the state, what parts of the state that is. Obviously, this is a much different issue, but so we have, for that rule to be effective, we both have to be in concurrence. We have to have the exact same rule. And so we have to go through this concurrent process. And rulemaking process is a long process. And if you look back, the top of this line, line 2, is by rule and regulation. So I guess what I'm saying is I'm a little hesitant to put concurrence. I would like us to actually go back to the original language, which is consultation. The Board of Pharmacy has the primary responsibility. They do that in consultation with the licensure boards instead of having each one of them have to have a set of rules that are identical. And that's at least my experience within the rulemaking process when I was on the Livestock Board, and that's what I'm putting forth as an option. I'd certainly ask LSO if they have any thought or suggestion on that. Okay. So there's a motion to accept that. There's a second discussion on that motion. Representative Halverson.
Thank you, Mr. Chairman. I would ask the committee, the task force, why this was changed.
Representative Clem.
Mr. Chairman, I think it was changed at our last meeting. I don't believe that it was changed. Yeah, this committee changed that. We originally had consultation, and I think there was some this is one of the things we talked about at our last meeting. So I agree. I think we should go back to consultation. That was the original intent.
And if I made the motion to change it that way, I'm making it back. Representative Halverson.
No, Mr. Chairman, in our October 5th draft, it's identical.
Okay, thank
So
you.
That's how it came to the committee.
Senator Peterson.
I think maybe, if I remember right, the concern was consultation is different than concurrence. We understand that, but concurrence brings us all on the same page. If you have different agencies or suppliers or boards with different rules and regulations, I think that was our concern was, concurrence brings us all on the same page, same rules apply, same boards, same, if I remember, I think that was because there is a difference between consultation and concurrence. Consultation doesn't solve the problem as far as opioids are concerned, but concurrence gets us all on the same page. Everybody's on the same. And so we don't create these markets or these loopholes.
Okay. Senator Scott.
Chairman, this is in the management of the system. And if you've got multiple professional licensing boards, it strikes me just going to be an administrative nightmare to get everybody exactly on the same page. So,
Representative Clem.
Thank you, Mr. Chairman. And that's the whole point. This is talking about the administration of the PDMP and what are the exemptions for using the PDMP. And there are certain instances, for instance, if you go into, if you're going to get surgery, let's say you have to have shoulder surgery, you're going to go in and they're going to dispense a narcotic to you. What we're saying in those instances, the board may exempt those certain instances where they don't have to query the PDMP if they're getting a medication right there. Now, when you get the paper prescription and all that, yeah, you're going to have to query the PDMP. But when they administer the medication in that setting, you wouldn't have to. Or another one in hospice, if you have someone who is dying, in that case, are we going to query the PDMP for a person who is dying and getting the medication directly? And those would be some reasonable exemptions, and that's why we're saying that the board of pharmacy who controls the PDMP can make those reasonable exemptions. But if you do say that all these other boards have to concur, you do create an administrative nightmare. So that's why we would like the consultation instead of concurrence.
For the discussion.
Question.
Senator Peterson.
Just to follow up on that, then why have consultation at all? If the board's going to do what they want to do, then why consult with other boards?
Fair question. So would you like to amend it to say a period after the word board on line 6 and strike the rest of the paragraph? Well, let's dispense with this one and then we'll go. I mean, because that's what you're talking about, if I understand you correctly. All right, further discussion on this amendment, on the amendment to go back to the original language, line 6, consultation versus concurrence. Senator Scott.
Chairman, I think we ought to pass this amendment because I think this will solve the problem. I do think the input from the other boards is important because that's where you're going to get some of the individual circumstances that need some kind of exception.
Further discussion, further discussion, further discussion. All those in favor of the amendment, please signify by saying aye.
Aye.
Those opposed, no. Motion carries still. All right. Further amendments on page 10. Page 10, sorry. Representative Halverson.
Thank you, Mr. Chairman. There's a whole lot of exemptions in this paragraph. It looks to me, and this is a note I made in October, but I remember it all came at very late in the day. It looks like the task force started with a good idea, and then a lot of what ifs and whatabouts came up. So they try all of that in this paragraph, lines 1 through 9. I would just like to ask the committee, are we comfortable with all the exemptions that we're unleashing by this language? If maybe we don't want to put some more sideboards in there.
Okay, maybe I'll
Just a discussion.
give some opportunity for, and this is more of a discussion point. There's not a motion on the floor, but discussion. Senator Baldwin, if you want to respond to any of that dialogue, thank you.
Thank you, Mr. Chairman. I would respond to that by saying I think the sideboards are there, and this is in place. And Representative Clem spoke exactly to this, and this is for surgery, for in the field stuff. When that paramedic is giving you a shot of morphine in the field, is that paramedic then required to file a report with PDMP then? And that's not very practical. Likewise, when you're having shoulder surgery and the person doing anesthesia gives you a controlled substance intravenously, is it practical for them to have to file a PDMP report? And that was one of the exemptions. And I believe it talks about that in emergencies and in the inpatient healthcare. And the other one is hospice. And I think, in my opinion at least, and I believe in the and I speak for myself, but I believe it was consensus of the group on the task force that all of those exemptions are necessary to try to prevent creating a huge complex mess, frankly. And I believe those sideboards are there. And I don't think, just looking at it, that we let anybody escape out of there. Somebody will always try to escape, granted. But I think these sideboards cover those situations in the inpatient and in the hospice settings, and that's what we were after.
Representative Halverson, then we'll go to Representative Clem.
Thank you, Mr. Chairman. So if the task force can assure me that they've examined any possible unintended consequences that this might be opening the door for, I get hospice, EMTs, surgery, and I will yield to the wisdom of the task force if they think that this is not opening the door or subject to terrible unintended consequences. Then I withdraw any reservations I might have on the paragraph.
Representative Clem.
Thank you, Mr. Chairman, and speaking through the chair to my colleague, Representative Halverson. You know, we were provided, I've got this piece of paper right here. This is from the Opioid Addiction Task Force. This has several states in which they have certain exemptions, or it prescribes the PDMP use and under what circumstances it has to do that. And what we found is that there are some states go ahead and do it by legislation, as far as the exemptions that they make, and it's very rigid. Others do it by rule. And I was just looking at Virginia's. Virginia was one that stuck out to me during this whole example. And this is, they have exemptions if it is prescribed to a patient receiving hospice or palliative care, 2, prescribed to a patient as part of a treatment for a surgical or invasive procedure, and such prescription is not refillable. 3, prescribed to a patient during an inpatient hospital admission or at discharge. 4, prescribed to a patient in a nursing home or assisted living facility that uses a sole source pharmacy. And as we got into all this discussion and in limited time on the task force, we were thinking, okay, what do we have to go? Or is it this? And we thought a better use of our time would be to give the Board of Pharmacy the latitude in the rulemaking process to identify, yes, these are the exemptions and these are not. Because there's going to be certain things that fit Wyoming that maybe some of these other states do that doesn't fit for us. And so that was the whole reasoning behind all that.
Perfect. Further discussion on that? Anything else on page 10? Thank you. Anything else on page 10? Page 11. Page 11. See how long she holds her hand up. Page 11. Representative Halverson.
Thank you, Mr. Chairman. If you recall in Casper, this whole subject came up rather late in the day, and you instructed us to give any suggested amendments to LSO, and we scribbled one out on a piece of paper, and bless LSO for getting it. I mean, it was rather hastily done. But it goes to the section line 16 to 23. Now, in our haste to address this, we simply asked LSO to prepare an amendment deleting the whole paragraph. That might not be entirely necessary, but what we wanted to address specifically is reporting individual names to the Medicaid medical director or the director's designee, we are fearful that someone might just play a little game of go fish. Send me all your oxycodone users in zip code 83118. We definitely saw this as a violation of the Fifth Amendment and the privacy that the Supreme Court has found in the Constitution somewhere. So I move the amendment that you have in front of you. That's my motion.
So there's a motion for you, and while it's a written one, there's a second, Stivar? Motion and a second, Halverson, Stivar. The motion is actually a deletion. There's not a deletion and insertion. It's just a complete deletion of lines 16 through 23,
Right.
page 11.
Right.
Is that adequate? Okay.
That's exactly right.
All right. So discussion on the amendment. Discussion on the amendment. Senator Peterson.
Thank you, Mr. Chairman. Some things we need to keep in mind here. These are public dollars that we're talking about, and there is some accountability, and accountability for patients, practitioners, legislators, trying to get a handle on this problem. And I don't know if you can see where eliminating this would hamper our efforts of trying to get good data to realize that we have an epidemic on our hands, and how do we stop it? How do we help it along? How do we bring doctors to accountability? How do we bring veterinarians to accountability? How do we bring patients and taxpayers and legislators to be accountable and recognize that this is an epidemic without good data? How do we do it? Ask me now. Is it an epidemic? I've been told it is. I mean, that's without good data, and this allows us to get good data back. And individually, yeah, we need to recognize some constitutional confidentiality and HIPAA violations and all those things. Yes, but to query a zip code and find out how many people are on opioids and we need that data to make good, solid decisions. Without that data, we're just shooting in the dark here. So I'm opposed to this amendment. I think this is a good idea and again, realizing that these are public dollars. These are tax dollars being used to work on this problem and to help people with pain management, what you want. But I find it so ironic. Before we had this task force and before we recognized it was an epidemic, this was probably 10 years ago. I had to go to a meeting as a state senator in my area, and it was doctors, law enforcement, task force on the local efforts to recognize that it was an epidemic and that we had to do something about it. So the doctor sitting at the table was known on the street as the candy man. And he was saying, this is an epidemic. We got to do something about it. And I was in the back of the audience sitting there shaking my head going, where are they getting this? From that doctor. I mean, he's creating the market, the black market. And it's so frustrating. But without good numbers and without good data, how do we attack the problem? And this is going to help us get those good numbers. And correct me if I'm wrong.
All right, further discussion, Representative Clem.
Thank you, Mr. Chairman. And I don't think this is actually going to give that good data because this is for individuals. So what this is saying is that you cannot query or get, as it says there in line 21, shall identify a specific Medicaid recipient to whom the request is related and shall not be used to conduct a non-individualized data matching queries. So they can't go, excuse me, Medicaid can't say, hey, I want to know zip code number or those who are getting opioids who are on Medicaid in this zip code. You can't do that according to this amendment. What this is saying in particular, though, is that in writing, someone has to, in writing, identify a specific individual, and then they can get some data. But here's the disconnect for me in all of this is that what I'm hearing Medicaid saying is Medicaid wants to know because they want to know what they're paying for. They know what they're paying for. They're the ones who are in control of the dollars and who are approving things or not approving things. They already know what they're paying for. What they're fishing for is how can if a patient decides to not use their insurance and pay for it out of pocket for whatever reason, they want to know about it. Is there merit to that? Sure. I don't know. Maybe there is, but that's the whole thing. It gets me confused. What's the purpose of this? And then to add more, more problems to this is that we talked about, it's not just Medicaid who's going to want this now. Once you open the door for Medicaid, next thing you're going to have Cigna, you're going to have Blue Cross Blue Shield, because they're going to want to know too, because by golly, they're payers and they have the right to know. And so you really open this door that it is really kind of dangerous. And the whole point that I tried to establish with Ms. Hunt is that we already have tools available to prevent. I mean, there's lines of defense that we have right now. And with the existing framework and structure and with the addition of these bills that we attack this, but this portion right here, I believe is a step too far. And I would agree. I think the deletion of it at this time is okay. I think we can come back and maybe there's some things that we can do later on, but I think this is a step too far.
Senator Scott.
Chairman, on and against the amendment, it does seem to me that there are other lines of defense, but you're talking about very busy people. You're talking about people dealing with a tremendous volume of prescriptions. You look at your local pharmacy and how busy they are. And people are fallible. They will miss things. They won't catch all the things they're supposed to. This is another line of defense, and it's an attempt to improve the quality of the health care in the Medicaid program. I don't think it's going to be used on a large scale. Maybe it should be. I think maybe Senator Peterson's right. It should be used on a larger scale, but the way it's worded, you really can't. But you can use it to improve the quality to the Medicaid population, where we have in general a problem with overutilization of healthcare services. So I think it would be a mistake to remove this from the bill. This is kind of a compromise between going all the way and say, let them query the whole thing for everything. And this says, okay, we'll limit that, but we will let them do it for the quality control purposes that they do need. So I urge us to defeat this amendment.
Further discussion. Representative McGuire.
Thank you, Mr. Chairman, and I would just offer to make sure that the record is correct, I think that we're talking about a Fourth Amendment.
Thank you, Council. Further discussion. Representative Halverson.
Thank you, Mr. Chairman. To my good friend, the senator from Cowley, I think if you scratch the surface of all payer sources, you're going to find some federal dollars. And I think that goes to Representative Clem's concern that what's next? Cigna, Blue Cross Blue Shield. And going to the cash, if Medicaid queried a pharmacy, and found a lot of cash pay
But once you cross that line and you take federal or public dollars, I think you sacrifice some of those things. And I think it's accountability on our part as legislators to, again, I mean, if Medicaid's the big brother paying for the bill, or at least half of it, they should have some say. They should have some inquiries. That's just my point, Mr. Chairman.
Thank you. Further discussion. Further discussion. Representative Halverson, or Hallinan, my apologies.
Thank you, Mr. Chairman. I think the PDMP is for the purpose of making sure that drugs are given appropriately. And this issue is one of insurance. I don't think that's appropriate to address that in the form of the PDMP. Therefore, I am for the amendment.
Further discussion. Further discussion on the amendment. Further discussion. All right, so we're voting on the amendment as presented. It's the elimination of this subsection 7 and the subsequent changes that elsewhere in the bill that are required. All those in favor of the amendment signify by saying aye. Aye. Those opposed, no. No. All those in favor, raise your hand. I think there's 8 showing, right?
Either 7 or 8.
6, 8. All right. Those opposed? 4, 6, 8. Thank you. Motion carries. Further amendments discussion on page 11. Page 12. Final discussion on the bill.
Question on the bill.
Final discussion on the bill. Seeing none. Roll call.
Representative Clem.
Aye.
Representative Dayton. Aye. Representative Guru.
Aye.
Representative Hallinan.
Aye.
Representative Halverson. Aye. Representative McGuire.
Aye.
Representative Stivar.
Aye.
Representative Sweeney.
Aye.
Senator Baldwin.
Aye.
Senator Boner. Senator Bouchard.
Aye.
Senator Peterson. Senator Scott.
Aye.
Chairman Barlow.
Aye.
14-0, Mr. Chairman.
Thank you very much. So this will be, I don't know, might be a Senate file.
We'll have to discuss that.
So I was just informed by staff that we are no longer broadcasting. So that does not mean, thank you, Ms. Hunt, for all your work on that one. We're no longer broadcasting. That doesn't mean you can stop using the microphones. We're back up. Never mind. So I think actually because we're a few minutes ahead and we're going to take a break. Some The warning shot.
No. If you're all right. I don't understand this one. Since this one thing, I think the other stuff is. Yeah. Yeah, I saw it.
Thank you. There's more over there, Mike. We have a straggling.
2, 3, 4.
We got a quorum. We'll just get started. So we're going to go ahead and get started, ladies and gentlemen. We got a few members that are still conversing with some folks in the hall and doing some other business, but we're going to get started. The next item on our business is 11:30, so we're not too bad, and we already taken the break. So mental health licensure, we're going to have the Wyoming Mental Health Professions Board here, and they are going to give us some insight. So those folks, whoever's going to present on that on their behalf, come on up. And they're going to present on some rule revisions, just give us hopefully a brief summary of some of the things they're considering within their rule revisions. And then they do have a bill draft before us. And ladies and gentlemen, just so you know, this will be the first time we've seen this bill draft. And as you recall, mental health and substance use is part of our interim charge. And as we, at our previous meetings, have heard some things with regard to licensure. I reached out to the board concerns with licensure and reciprocity and different things. I reached out to the board and said, look, if we know you're working on these issues, if there are things you would like from the legislature, i.e. you need some authorities that you don't currently have, please let us know. So that's what they're coming forth with. So the bill draft will be on authorities that they would like, the authorities they would like. The rules, of course, they believe that's within their authority, so they're going to give us a summary on those revisions, and then certainly when you open up a practice or an act, then other things may come. And I see we already have a couple amendments to potentially to this bill draft. So, with that, I will Dr. Heenan, I believe, right? Well, if you would, pull the mic close to you. We are streaming live, so the entire world can hear your fine words. And welcome. And if you'll go ahead and introduce yourself, or whoever is going to take the lead. I guess you're the chairman of the board, so if that's appropriate, you take the lead, introduce yourself, and proceed. Thank you very much.
Thank you, Chairman and committee members. Yes, I'm Dr. Kelly Heenan. I
Pull it
am
closer. Yep, please.
board chair for the Wyoming Mental Health Licensing Board. And beside me, I have
Lance Godey. Lance Godey. I'm past board chair and the counseling representative on the board.
Good morning, members of the committee. I'm Greg Searles, the executive director for the Mental Health Professions Licensing Board.
And as you stated, we are here to begin by addressing some of the rule proposals that we have done. I would like to just briefly go over those that I think have been most pertinent to the committee, beginning with reciprocity. We have sort of looked at a three-prong approach to reciprocity, looking at education, which is defined by statute for reciprocity, a passing exam score for that certification or licensure, and then looking at for the past 5 years, anywhere that certification or licensure has been held, has it been held in good standing without any form of discipline on that degree? And if a candidate for licensure or certification would meet those three requirements, they would be granted the licensure or certification in the state of Wyoming.
Dr. Heenan, would you, can you thumbnail how that is different than it currently is? So what is that change actually accomplishing in your view? How is it going to add more people availability? Is it just more context to the rules? What does it actually do, these rule changes? What is the practical outcome of these rules changes? Thank you.
Yes, Chairman Barlow. Currently, in the way that the rule was interpreted, we looked more specifically at the education and did almost a transcript evaluation for reciprocity, looking at did they meet the same similar education requirements as a new licensee would have to meet in the state of Wyoming. This would take that out if they just had the degree, an equivalent degree. So if they have a master's degree in marriage and family therapy, and they've passed the national exam in marriage and family therapy, and they've held a good standing license in marriage and family therapy in any other state, that would then be granted versus having to go back and look at, did they require all the education requirements that we required? We also eliminated references, and that was something else that we had required. And so we took out that to speed up the process for reciprocity and all licenses, initial applicants.
Thank you. Any questions from the committee on Representative Sweeney?
Thank you, Mr. Chairman. I noticed a couple of things. You've in almost, well, every section on reciprocity under any of the licenses, under reciprocity, you've taken out the language on substantially similar. Could you explain why that's been taken out? And in that context, do you feel that that will make it easier if substantially similar is taken out?
Thank you, Chairman and Representative Sweeney. We did take out substantially similar because in our discussions and looking at it, it was interpreted not consistently by each board member. And so by taking that out and then broadly defining the 3 criteria, it should make it much more quick, the process much more expedient in order to obtain the reciprocity and clear in regards to what exactly are we looking at for any new applicant.
Thank you, Dr. Hina. I want to be clear, folks. What we're speaking about now and when she's providing testimony on the proposed rules, this is not the bill before you. This is the proposed rules. And let's try to take it topic by topic. So let's stick with the reciprocity issue since that's what she presented first. So if you have a follow-up, Representative Sweeney.
Yes. And again, back to reciprocity, specifically on the rule changes. In some cases, in the rule changes, it appears to me that you're still tying everything back to that degree, and even on reciprocity, still going back and treating almost as though it's a new application again, even though it's a reciprocity issue. So in my mind, you really haven't fixed some of the problems within these rule changes on reciprocity. And back to the degree comment, do you feel in your rule changes that you've done on reciprocity, do you take into account their actual work? Instead of tying it directly to a degree, like a bachelor's degree, do you feel that you're taking into consideration they've got 5,000, 8,000 hours of practice into account? Because I don't specifically see that.
Before you respond to that, Dr. Heaton, I want to make a comment. So let's be clear. What I've asked the board to do here is, as a courtesy to this body, to understand the context of the bill that's going to become, is kind of give us an overview. These rules are not out for public comment yet, or they are out for public comment. So they could consider this as a public comment period, but I want to be a little cautious about getting into a back and forth about what their intent is, because these are out for public comment. That's an executive branch function. And we can give them some feedback, but I don't think we need to get in the back and forth. Are they doing the right thing? with these rules. If we don't think it's adequate, then we can do something legislatively. We can also ask our LSO to take a hard look at it when those proposed rules come through or they're approved. So I just want to be a little cautious that we're not actually litigating their rules. You can point out things and ask for clarifications, but I would be, and I'm not speaking just to you, Representative Sweeney. I just want to be cautious that that is a separate administrative executive branch process that they are going through. We can ask about where they are in it and how, but I think I want to be a little careful about going too far into the details of where they are and how they've come into those decisions. First of all, because Ms. Heenan, Dr. Heenan is an individual on a board that is putting these forward. She is not solely responsible for that. So I would ask for a little bit of latitude to be cautious about that. So do you have and I apologize, I know I interrupted the question process, but I want to be clear here what we're doing here. This is a courtesy discussion from them. We can certainly inquire, but I don't think we can ask them to draw conclusions or advance things that are beyond their individual authority. So if you're welcome to respond to whatever I can't remember what Representative Sweeney talked about, but go ahead, Representative Sweeney, if you want to clarify.
Well, I'm just trying to understand the proposed rule changes. So if I am going too far, I'm glad not to ask questions, but I'm just trying to understand what the board's trying to propose. So
Chairman Barlow,
Go ahead, Ms.
mind
Heenan.
responding quickly to Representative Sweeney. The degree was not addressed in rule changes as it's a statute. It's addressed in statute that they have a certain degree.
thank you.
Mm-hmm.
Thank you. Representative Guru.
Yes, Mr. Chairman, I have a procedure question with regard to these rules. And I think it's just a typo first. This is data public notice, November 26, 2018. Comment period ends January 13, 2018. I assume you mean 2019.
What page are you on?
The first one. The top.
Mr. Searles, go ahead.
Representative Barlow, Representative Guerrero, you're correct. That is a typo, and I believe that has been corrected in the online posting. I believe Kendra caught that, and I just forgot to change it when I printed these for the board. I apologize.
And if I can follow up.
Go ahead, Representative Guru.
One other question is, if that is the total period of comment time, how are you pushing this out to the people you're asking for comments from? How are you pushing this out to them? Because that's a fairly short time frame. It includes holidays and stuff. So I just wanted to make sure you were getting the comments you want to get from this, from the people you're getting it from, about just a short time frame.
So, thank you, Representative Gru. So to be clear, the time frame is probably consistent with the Wyoming Administrative Procedures Act. So that is something that we outline as minimum time frames. As far as the question of how they're getting the comments or soliciting comments to the interest groups, I'll leave that to Mr. Searles.
Thank you, Representative Barlow, Representative Guru.
I think that mic is not on, I don't believe.
Sorry, it's not on?
Okay, that's right.
In response to your question, sir, we have posted all of these rules to our website at this time. We have emailed them to all licensees. We have also sent an official postcard to all licensees indicating that they're out, where they're available, and the setting for the hearing. As far as the public comment period, the public comment period is required to be 45 days. This is actually closer to 60 days. So we felt that was equivalent enough with the holidays involved in the middle of all this.
Thank you, Mr. Chairman.
Okay, further questions on the rules? Further questions on the rules? Do you have anything else to go through on the rules?
There was only one other small, thank you.
Go ahead,
Chairman.
please.
I was going to just address under renewal. We looked at CEU requirements as that had been another major concern by constituents. And we eliminated the requirement for those providing CEUs to have a graduate degree. And we will look now just at scope of practice and relevance to the sense.
Okay. Senator Scott.
Mr. Chairman, I have been hearing some complaints about difficulties in getting people licensed by the people and basically coming from some of the people that employ them. Do you think these rule changes are going to go a long way to satisfy those complaints? Do you think those complaints are valid? Do you need something further in the way of statutory change?
Ms. Heenan.
Yes.
Dr. Heenan.
It's okay. Yes, Chairman Barlow and Senator Scott. I do think that these changes to the rules will expedite the ability for people to be licensed in the state of Wyoming in a much faster rate. I think it will open up some different avenues. And as we will get into in the next agenda item, we have also looked at creating an additional track for certification and employ labor within the state of Wyoming. So I do believe we are addressing the need to have more mental health professionals.
Further discussion on the rules? On the rules. Representative Halverson.
Thank you, Mr. Chairman. Doctor, have you had any feedback? What have the comments been looking like?
Go ahead, Dr. Heaton or Mr. Searles.
Yes.
Thank you, Representative Barlow. Representative Halverson. At this time, the board has not received any public comments in the week that they've been out for public comment.
Further, Representative McGuire.
Thank you, Mr. Chairman. I'm looking at section 5 of the rules, I believe, certification of reciprocity. And I'm just curious to make sure that if you feel that there are enough safeguards. We had a issue in the center part of the state where there was a physician who had been accused of bad deeds in another state and had agreed to give up his license, and at the same time, and in that gray space, was licensed in the state of Wyoming, came to Wyoming, and then of course was eventually convicted of doing the same thing in the state. I just want to make sure that this is not creating a catch-22 where somebody could work the system, they get into trouble in another state, agree that they will give up their license, but then prior to giving up that license, apply for and move to the state of Wyoming. So I just want to make sure that you feel that you have enough leeway in there that you can sufficiently investigate something like that.
Go ahead, Dr.
Thank you, Chairman and Representative McGuire. It does require that they have proof of evidence from another state that their license is in good standing and without a complaint. Had a complaint been finalized, we would know that. If it was in process and severe enough, I'm going to speak slightly out of, maybe Greg can help me. I believe there's a national reporting for those instances that we could also tap into, but maybe, Mr. Searles, would you like to?
Go ahead, Mr. Searles.
Thank you, Representative Barlow. Representative McGuire. Currently, the board does not have background check authority through the state, so we can't run background checks. We're required to rely on the information provided by the applicant.
Okay. Follow up, Representative McGuire.
I'm curious about that. Most other professions, realtors, attorneys, even people who work in the school system are subject to a background check. Why would somebody who is in a room alone with people providing mental counseling, things like that, why would that person not be subject to a background check?
Searles.
Representative Barlow, Representative McGuire, for the simple fact we don't have the statutory authority from the legislative body to be able to require that. We have to have that authority through statute, and I can't reason for the body as to why we don't have that authority, but it has not been given to the board.
Senator Scott.
There's, I think, a practical reason here. That system has been just incredibly backed up. We've been so free with giving that authority that we have overwhelmed things, and I've heard a lot of complaints that it takes forever to get the background check done. So that's a reason to be a little cautious for that one going forward.
President McGuire.
Well, I guess I would push back a little bit on that. I've had a person come on board very recently that, again, through the real estate rules, had to have a background check, and once she submitted the forms, it came back right away. And so I would say that they're probably caught up, and that person would be, in my opinion, a far lower threat than someone who is providing counseling services to people. That would just be an anecdotal comment.
I sense an amendment coming, so would LSO please look for the appropriate language? Further discussion? Or Representative Sweeney.
Mr. Chairman, I'm not sure direction. I do have questions like chapter 3, chapter 4, in on the rule changes.
I guess
proposed rule changes.
I guess we're not here to work their rules. And so if you can frame in the broadest sense, how does this improve the current system, or what does that provide? I think we can do that. I would also caution us that we have that amount of time on the clock, and we have a bill before us, and we have some other folks that have traveled here to talk about a couple of other mental health agenda items that are not on the subject, or not on the agenda. So go ahead, but I'd like it to move as quickly and as I'd like it to be focused on authority they have or don't have that you would like them to have. How's that?
Okay, I'll try my best. Thank you, Mr. Chairman. First question relates to chapter 3 on the cap. According to the proposed rule changes, a regional institution of higher education would be required to have the NASAC accreditation to meet this standard. What current regional institution of higher education in Wyoming satisfy that requirement in the proposed rule changes? Within.
Go ahead, Dr. Heenan.
Chairman Barlow and Representative Sweeney, Casper College has that accreditation.
And
follow up?
In that sense, Mr. Chairman, is that a bachelor's degree or only an associate's degree?
Dr. Heenan.
Chairman Barlow and Representative Sweeney, through Casper College, that's an associate's degree. They would then have to obtain the bachelor's.
Representative Sweeney.
So my concern there in the broader sense is tying this back. There's really not a clear-cut way or rules. If you graduate, say, from the University of Wyoming, you really can't get licensed with our licensure board, but you could in Nebraska. So is there a way in the broader sense to take care of that?
Dr. Heenan.
Chairman Barlow and Representative Sweeney, if you're looking at the section 3B, there's an or into C. So it's not the sole, it's an or.
Okay. Is that in the proposed or in current?
Proposed.
Proposed. Okay. And follow up, Mr. Chairman.
Yes.
You feel that the or will help alleviate that?
Yeah.
Go ahead, Dr. Heenan.
Yes, Chairman Barlow and Representative Sweeney, yes.
Okay. Thank you.
Further questions on the rules? On the rules. Further questions? Senator Bouchard.
Thank you, Mr. Chairman. You know, I'm looking through this. It looks confusing, so I'll admit that right from the start. Where I'm having the problem is the problem we've had all along here was that we've had people come into this state with a similar license, and the board was actually going through and looking at the entire list of what their training was from another state. And as far as I'm concerned, some of these states are more advanced than us, but they may not have one thing that was in their transcript. And we're holding these people up that have moved here to come into the state. We've got an agency that's not an agency, but a for-profit provider that can't get people to work. And I've even been to your board meetings myself, and I do appreciate you being here. Don't get me wrong, but we haven't been able to communicate and try to fix these problems. So, can you show me where this is going to fix this problem in this set of rules?
You can speak broadly about the efforts you made. We're not going to go through the entire sets of rules to get to that, but go ahead, Dr. Heenan.
Thank you, Chairman Barlow and Senator Bouchard. In the reciprocity, which is, I believe, what you're referring to for those who would be certified or licensed somewhere else, we are looking solely at the degree being similar So do they have a similar degree, bachelor's level or master's level? That transcript evaluation would no longer occur. That you're speaking to look at is a certain course there or not there. Have they had this one thing versus not this one thing? It's solely the degree, which is defined by statute.
Right. Further questions? Further questions? Representative Sweeney.
Thank you. Mr. Chairman, if I could turn to Chapter 7. I'm going to skip. I do have a series of questions for Chapter 4, but I won't go there. But Chapter 7 in particular, on the provisional licensing, is provisional, is it applicable in your new rule changes to across the board, or is it masters only?
Dr. Heen.
Thank you, Chairman and Representative Sweeney. It's masters only.
Representative Sweeney.
I'd like clarification why it's masters only and why we wouldn't look at other licensures, say even to the bachelor's or possibly associates on a career path or a path.
Go ahead. If you have an answer, go ahead. If you're not sure of the answer, that's fine too, and we'll move on.
Thank you, Chairman Barlow and Representative Sweeney. I'm not sure I fully understand your question to be able to answer it.
Why is it, Mr. Chairman, why is it limited to masters only, not provisional?
Go ahead. Someone like to respond?
Representative
Mr.
Barlow,
Searles.
Representative Sweeney. I believe provisional licensure is defined in the statute as a means for those with a master's level degree to seek independent licensure. And that would be why it would only apply to master's levels, because I believe it's defined that way in statute, if I remember correctly, without fully pulling the statute up in front of me at the moment.
Representative Sweeney, follow up.
Is it possible to have LSO check that? Because I think that if it's statute that's dictating that, that would be something I'd want to run an amendment on.
Somebody from the staff take a quick look for that, please.
Could I?
Let's go on to someone else for a bit.
Thank you.
Representative Stivar.
Yes, in Chapter 7, you just said you guys couldn't do background checks. On B, where it says no felony convictions or misdemeanors, is that new? Is that a rule change for you guys?
Go ahead.
Representative Barlow, Representative Stivar, that is referring to anything that's reported to us. That doesn't give us the ability to perform those background checks. It allows us to ask those questions on our applications if they have those type of felony convictions or misdemeanor convictions. And the change in that rule is to reflect the statute that was done last year, so that affected the moral turpitude clause that was in there prior, and remove that. So we've changed the language in all of our rules to reflect that statute.
Thank you. Further discussion on the rules. Then we're going to move on, and we will come back to the question that was inquired. Go ahead, Representative Sweeney. Do you have something additional?
Yes. Thank you, Mr. Chairman. I turned your attention to Chapter 12, the application procedure. On 12.3 of the proposed changes, and in particular, Section 6 on 12.3, application for certification of reciprocity. The change is, additionally, the applicant shall submit official transcripts from all colleges, universities required by the application, as well as verification that the application has achieved a passing score. The board may rely upon documentation verified. So my concern here in Chapter 12 on reciprocity, I'm still not seeing in the changes, the application process, I don't think, and hopefully if the amendment I plan on bringing forward will better clarify on reciprocity, the difference between a new applicant and reciprocity is my attempt. But do you have a feeling that on the application process that you truly have a clear-cut differentiation on reciprocity with these new rules between a new applicant and reciprocity, or am I misreading?
Dr. Heenan?
Chairman and Representative Sweeney. Yeah, again, the transcripts would be requested to verify the degree, whereas in a new applicant, we would be looking at a transcript evaluation to ensure they have all the required coursework. This would be verifying the degree.
Thank you.
Further discussion on the rules. Further discussion, Representative Halverson.
Thank you, Mr. Chairman. Doctor, when were the rules last revised? Has it been
Whoever
some
would like to
time?
respond, Mr. Searles.
Chairman Barlow, Representative Halverson. The last change to the rules was in 2013 based upon Governor Mead's request for reduction in rules.
Okay.
Follow up. Follow up.
Thank you. Not necessarily a follow-up, but an inquiry. Yesterday, we heard from a presenter about peer support in recovery, drug, mental illness recovery programs. And recently, a Wyoming reporter went to North Dakota and learned more about peer support. Do you anticipate any rules regarding licensure of peer support specialists?
Go ahead, Dr. Heenan.
Chairman Barlow and Representative Halverson, at this time, that has not been up for discussion with the board.
Okay, thanks.
Further discussion, further discussion. All right, so I think we're still circling around on the provisional issue question, but we'll come back to that when we've got it. And so let's go on to our proposed bill draft. And the bill draft before us is 305.2, version 0.2. And ladies and gentlemen, this is a draft that we're just going to ask the presenters to walk us through and give us, I guess, their why the request is here, and we'll go from that. This is the first time we've seen it, so there might be questions. So please proceed. However, whoever wants to proceed. Dr.
Thank you,
Heenan.
Chairman Barlow. Yes, you have before you a draft that we have put forth. The third page just has one small minor change with regards to degree. We had human resource in statute. We would like to change that to mental health discipline, as human resource gives the notion like HR in outside fields, and we think mental health discipline would relate better to what our scope of practice is and what we do. And then
Dr. Heenan, if I could, because I actually queried the entire statute for both of those terms, and neither one are actually defined anywhere when it comes to a discipline or et cetera. So I guess give some thought to whether a sociology degree or a psychology degree, as is currently recognized as a human resource degree, still falls under that category as a liberal arts type degree, or if we're being more specific with psychology or psychiatry or something like that. I would just throw out that we're probably, and maybe you're doing it in your rules, having a definition in your rules, but sometimes in statute, it's not a bad idea for us to have that understanding what's being referred to. So go ahead.
Thank you. And I could just jump back. Thank you, Chairman. Just jumping back quickly in our rules, we did say a degree in human resource discipline is a degree in addictionology, chemical dependency, substance abuse, substance use disorder, psychology, sociology, or a related field. We did attempt to define it there.
But you're not using the term mental health discipline.
No.
Mr. Searles.
Representative Barlow, the reason for that is when we were writing the rules, we weren't sure this draft was going to go anywhere. So we addressed the current issue of it saying human resources so that that's in our rules. I believe if the board, if it was changed to mental health, would stay with a very similar definition as to what we define that human resources discipline as.
Okay, thank you.
Mr. Chairman.
Representative.
Could I
Sweeney.
also add?
I don't think your mic is on.
Thank you, Mr. Chairman. The other terminology that I might throw in there is human behavioral. And I don't know if that's defined any place either that might be a broader sense versus human resource.
Okay, thank you. I see an amendment that has that term, so coming.
Just a thought.
All right, thank you. Please proceed.
Yes, Chairman. Moving forward into pages 4 through 12, there's a lot of areas that have been struck, and those are all areas that were grandfathered in or outdated language, so we would just like those removed from the statute. And then at the bottom of page 12, you'll see a certification for a certified mental health worker. This certification mirrors the language that's currently in the statute for all other certifications, but creates a different level of certification under the counseling spectrum. So we have certification under social work, certification under substance abuse. This would create a certification under that counseling realm as well.
To be clear, if I could, Dr. Heenan, this actually is already defined in the statute and was inadvertently removed at some point during modifications, or how did we get to this point where we don't have the authority to do it, but it's actually defined in statute? Go ahead.
Thank you, Chairman. Yes, it is currently defined in statute, and it was a grandfathering clause at the time. And
go ahead, Mr. Searles.
Representative Barlow, yes, it was a grandfathering that created this level of licensure, but there was never any further allowance to create it permanently for those as licensing was developed in 1998. So it was only grandfathered in and created. We'd now like to make it a permanent fixture because we do still have people working as certified mental health workers in the state, and we're trying to create that other avenue, as Dr. Heenan said, for counselors.
So I want to be clear. You have people, you're not licensing certified mental health workers because you don't have a means to do so, but there are people still doing that work. Is that what my understanding is?
correct, Chairman.
Thank you. All right. Any questions on the, so this is all the new language, and this goes from the bottom of page 12 all the way 13 and 14. It's all the new language, essentially, on those pages. So any questions on that language? Senator Bouchard.
Thank you, Mr. Chairman. You know, I'm just question LSO, and because I'm trying to, if we're striking something, it's there. There isn't another part that says, well, you can't use it because it was grandfathered in and it's just there. And quite frankly, the answer that came back to me, they don't know what, LSO doesn't know what you referenced when you're saying that this couldn't be used. As I read that language, it looks like a lot of this could have been used to fix the problem we've been having. So I'm kind of stuck here.
So I'm gonna take a stab at it, and certainly the board representatives can take it. So I'll just take you to page 5. Look at lines 10 and 11. And this language is all included here because it was basically a licensure without examination. When these new rules were put into statute, when the new statutes were put in and created all these things, they had to somehow deal with the folks who were already doing the work. And that's how they accomplished that. So this was a bridge, and that's why you'll see dates. These folks can do this if they were, i.e., prior to 1997. And the next one will be for another licensure on another page will be for another one, and it'll be prior to 1997, page 6, line 13. The next one will be page 7, line 13, prior to 1997. So actually, all of these subsections, the way I read them, are no longer applicable because they are beyond the 2 years, they're beyond 1997, and they're not functional. And they are mirrored in the authorities we've given them for current day. So we gave a bridge, a way to get folks that had licensure prior to licensure now, and we've covered that elsewhere. So that's why I think this language can go away. Is it good language? Absolutely, it's good language, but it's no longer necessary because we're not in a bridge place. Is that an adequate explanation that I did on behalf of the board?
Chairman Barlow, yes, I do believe you did a great interpretation.
So Senator Bouchard, any follow-up on that?
Thank you, Mr. Chairman. I get the part where it's dated, but there are other parts in here that are not. So that's kind of what I was talking about, the parts that did not have specific limiters on it.
Further discussion. I guess we're on the totality of the bill. Totality of the bill now. Questions for the agency? Questions for the board, excuse me. The board. Questions for the board. So we'll go to public comment now. Anybody like to, all of you don't have to run away. If folks like public comment, there's a seat at the end of the table there. And so if folks want to make public comment on 305.2, please come forward. Come on forward. Welcome, Mr. Craig. And so we're taking comment on the bill draft before you. Or things you would like to see in a bill draft before you.
Thank you, Chairman.
Pull that mic up close to you, point it at you, and fire away.
Thank you, Chairman, members of the committee. I appreciate the opportunity to speak this morning. This has been a
Would you introduce yourself?
Yes.
The whole world is listening. Introduce yourself.
My name is Frank Craig. I'm the state director for the Gateway Foundation. We provide the contracted substance use treatment to the Wyoming Department of Corrections. And just a little bit of background for myself, I've been doing this kind of specific scope of practice for addiction therapy for about 20 years now. I was licensed independently in the state of Texas, having only a bachelor's degree in sociology, but Texas had a bridge or a mechanism in place so that I could start work immediately after graduating college, and the utilization of training within the scope of practice for 2 years for 4,000 hours before I could take the certification examination, which is recognized here in Wyoming as the same, to become independently licensed to practice. I did conduct supervision during the course of my tenure. I ran facilities with clinical staff, up to 48 clinical staff, where we had to do the same kinds of trainings and bringing them into practice very similarly. And so I say that because the organization that I work for, Gateway Foundation, has been around for 50 years. And that's the scope of practice that we do in 9 other states currently, but we've been in and out of other states so that we are very familiar with what national standards are for the requirement within the scope of practice for substance use disorder therapy. I do want to commend the board for the work that they have done looking into these rules. I think it's a great start, but I do believe that we have quite a ways to go to be able to bring us up to national standards, in particular where things like reciprocity would be important. I did pass out some handouts. One is simply an article that speaks to the confusion that goes around from state to state, where different states have different requirements for licensure, and how that needs to come into play on a national level so that the field of addictions practice can be unified with quality people that are meeting the standards that are set nationally to practice within the field. There's also an additional handout that is mentioned in that article that talks about building a career path that would allow somebody, for example, to move in from an associate's level up to a higher level of certification that would be based on their work experience and the type of examination that they're able to show proficiency by taking and passing. currently in Wyoming within the scope of the addictions therapy practice. There's 3 different levels. There's an associate's level, the CAPA. There is a bachelor's level, the CAP, and then there's a master's level, which is the LAT. And while we do have a partial career path that's strictly based on the education level, as you can see in the career path from a national standard, it would take an associate's level by experience as an in-training practicum, if you will, or internship that such that over the course of a few years, they would be able to bridge from the associate's level to essentially the bachelor's level or the CAP level that we have in Wyoming without necessarily having to have that specific bachelor's degree in place. That brings into question what their experience level is, and the competency of course comes from passing the examination that a level 2 or a CAP would need to pass. Interestingly, in the state of Wyoming currently, there is no higher educational institute that you could go get the bachelor's level or even a master's level and meet the current criteria that the board has established for those specific certifications and licenses. The Casper College did create a little bit of a pathway such that a person that graduated from the University of Wyoming, for example, with a bachelor's degree in psychology, would have to then go to an outside agency of higher education to gain additional coursework to be able to apply and satisfy the requirements of the current rules. If there was a way, and I do hope that the board might consider a way to utilize a person's work experience to be able to count towards the certification, and that may be where Representative Sweeney was asking questions about a provisional type of certification, whereas the current rules and even statutes outline that provisional as a master's level. In my own experience, even though I started practicing counseling with a bachelor's degree in sociology, that was under an internship that was set up within the rules and regulations in the state of Texas. And I had to complete 4,000 hours of supervised work experience before I could go take the required examination and show proficiency. But that allowed me to begin working in that capacity and then working towards the actual independent license that I still hold in Texas, if that makes any sense. I do want to stress that this is within the scope and practice of addictions therapy. That's my expertise, and I wouldn't pretend to try to change anything that might fall under another type of discipline that the board oversees. That would not be my objective, but I do think that it would be advantageous, and especially for trying to build the addictions therapy discipline in the state of Wyoming, to be able to make it easier to obtain and to begin working, and even in cases of reciprocity. The opioid crisis epidemic, of course, is an urgency for the need of this specified field, as well as just the fact that we have a neighboring state now that legalizes marijuana use. We've seen the implications of that. I know at some point Wyoming is probably going to have to make that decision as well. So I believe it's imperative that we continue to move forward with the changes through the board to be able to build the field here in Wyoming and set the foundation that we can handle those kinds of challenges moving forward. Thank you.
Okay. Any questions for Mr. Craig? Questions for Mr. Craig? Representative Clem.
Thank you, Mr. Chairman. And I'm trying to wrap my head around the proposed rules and this new language. Here's the thing, bottom line, just, talk to me, shoot straight with me. Are we making it easier for reciprocity? Are we making it easier for people to practice in Wyoming? That's what I want to know, because that's over the course of the interim, what we've been hearing is we're having a heck of a time. Number one, we need counselors in Wyoming. And number two, we're having a heck of a time getting them licensed. And it seems like there's arbitrary roadblocks and it sucks. So are we making it easier now, or are we making it harder or the same, based upon really not so much with the rules, but with the proposed change in statute? Is this going to make it easier, or are we just going to continue the status quo, only we're just kind of shaking things up a little bit? Can you talk to me about that?
So my kindergarten teacher wife would say we're vacuuming. We're not doing the other. We're vacuuming. Go ahead if you'd like to respond to that.
Thank you, Mr. Chairman and Representative Clem. From what I can see in the proposed rule changes, that it still lacks. Currently, I have 2 applicants that hold bachelor's degrees in psychology who have had some practice. One has worked as an investigator for Child Protective Services in the state of Nebraska for 3 years. The other has worked as a caseworker for the Wyoming Department of Corrections for the last 3 years. They have some basis for knowledge. They have the bachelor's degree, but they don't meet the criteria to be able to have the certification to practice.
Okay, so first of all, let's be clear. We can make general comments about the rules. That's not what we're actually, topic we're on right now. We're actually on and Mr. Craig and anybody else in the public has the ability to interact with the rulemaking process and provide comments, which they have received none to date, about what they'd like to see differently. So anyway, so I just want to be clear. We're on the bill before you, and I know there's some suggestions coming for that bill, and Mr. Craig's been involved in some of those discussions. So I'm going to ask a question about the bill and the certified mental health worker. Does that have any role in the work that you do within your both institutional work, and do you think that has any value within the broader counseling availability? Thank you.
Yes, Mr. Chairman, if I'm understanding your question, are you referring to the language for changing human resource?
No, I'm specifically talking about the new certification that's being proposed under these rules. We're adding another type of certification. Is that something that you see a value within your institution, or as a value more broadly in the mental health world?
Yes, Mr. Chairman, I would think as it would present to the scope and practice of addictions therapy, that might not necessarily be helpful in that capacity because of the scope of work, again, that we do.
Thank you. Representative Clem.
Yeah, thank you, Mr. Chairman. And this is really for any of you. When I look at this and looking at page 12, the new language, it says certification under this subsection shall allow practice as a certified mental health worker only under the supervision of a qualified clinical supervisor and subject to any other restrictions. I guess my question is and I was just trying to look through the old language. Is that an arbitrary roadblock when we say that you can only be certified by someone who is overseeing you? Or is that common practice? Or I guess I just want to make sure we're not setting up again an arbitrary roadblock for licensure in the state.
Dr.
Yes,
Heenan.
Chairman Barlow and Representative Clem, all certified licenses in the state of Wyoming are required to have supervision. So this is just indicating that if you hold this certification, in order to work, you would have a supervisor overseeing that work that you're doing.
This is a standard of practice for all those other certifications that are out there currently.
It's not an independent practice at the certification level.
Further discussion on the rules before you. Mr. Craig, go ahead.
Thank you, Mr. Chairman. If I could speak very shortly to that, the supervision level within the scope of practice for addictions therapy is driven by national standards that are set forth in a manual called TAP 21 that's put out by SAMHSA. That's a national organization, and there's a supplemental book that is for specifically clinical supervision within the scope of that practice. And most states allow a bachelor's level to have independent work, maybe not as a license, but to be able to not have to have assessments and treatment plans and other documents signed off on by a higher level, because at that at that bachelor's level nationally is recognized that you have sufficient information and knowledge to be able to do so. But to conduct the clinical supervision aspect nationally, there are courses that are being required. Usually it's about a 40-hour course, and then you become recognized on a national level as having sufficient knowledge to do clinical supervision. It's really not tied to the type of degree that you have or hold. And so in response to your question, that could be a barrier.
And I'm just going to make a comment on that. If we believe it's a barrier, then it's a barrier that the legislature has created, because if you look at the definition of qualified clinical supervisor, it is a licensed individual. By virtue of license, that means they had to meet other already requirements, including educational and experiential, et cetera. So if we want to get into that, that is something that we go into our own outline, our own rules, our own standards, and we have to examine that there and see the consequences. Now, be clear, Mr. Craig is talking about one of the professions, and there are multiple professions under this. So we start tinkering around. We got to be careful how we impact other professions, and certainly the board's work itself. So further discussion on the bill draft, public discussion or questions for Mr. Craig. We're in public comment. Further discussion, questions for Mr. Craig. Thank you very much, sir. Oh, Senator Scott.
Mr. Chairman, and I'm not sure I understand all the complaints.
Use your microphone.
That were raised, but if in the bill we were go to page 9, line 21, where it's certification without examination of a certified addictions profession, if we were to reinstate that language and put it wherever would be appropriate in the bill and reinstate it through page 10, line 19, or through page 10, line 15, to what extent would that solve some of the problems that you're talking about? The effect of that would be to enable the use of somebody who really had a lot of practical experience and be able to get a certification, not a licensure, but a certification that way.
Go ahead, Mr. Craig.
Thank you, Mr. Chairman. And Senator Scott, that, and again, within the scope and practice for addictions therapy, again, would allow a person to be able to operate, not necessarily in an independent capacity, but the ability to be able to do assessments and things like that, being recognized by the board as being capable to do that. What the clinical supervision barrier would be is having to have that licensed individual to provide that oversight, and there are stipulations within the rules and within other states have the same capacity where you're limited to the certain number of people that you're allowed to provide supervision for. And so in that sense, when you're an employer like Gateway Foundation, and we have 28 employees, most of which are clinical, and at the bachelor's level, it's a 1-to-5 ratio for supervision by rules. We were able to request an exception from the board to be able to do more, supervise more with one person, but I've only got one person right now that's capable to do that.
Further discussion. Go ahead, Senator Scott.
Chairman, I did not understand the answer. Would restoring that language, getting rid of all the date provisions that are subsequent to it, does that solve your problem, not help it, solve it partially? What progress would we make if we did that?
Mr. Craig.
Thank you, Mr. Chairman. Senator Scott, I believe it would be helpful. But I would have to defer back to how the board would promulgate rules to support that.
Okay. Further discussion? Further discussion? I'm just going to point out on that line of question that with that in place, you're nullifying the licensure, or you have the potential of circumventing all the licensure requirements the legislature has laid out previously, i.e. in 1997. So for a select group, so we start to get cherry picking, and so I just throw that out there, and they are actually fairly easy to find. They are 1 through 5 on in 106. Anyway, further discussion, as Chairman Scott.
Mr. Chairman, and the reason I'm thinking of doing that in this one is I think that there's considerable evidence, and what I've heard has been anecdotal evidence, but that someone who's had the problem themselves may be uniquely qualified to help others get out of it. And you may want proper professional supervision, and that's a separate issue. But I want the ability to use such people, and that's what I'm exploring, Mr. Chairman.
Thank you. Further discussion on for questions for Frank? Mr. Craig, thank you very much. Anyone else want to provide more public comment on this bill draft? Public comment on this bill draft. Going once? Get going. Let's go. Thank you.
Oops.
Go ahead, Mr. Demple.
Mr. Chairman, members of the committee, I'd like to
go ahead and introduce yourself, please.
I'm
for
sorry.
The world.
I'm Paul Demple. I'm the CEO of Northern Wyoming Mental Health Center, as well as a member of WAMSAC, who is the statewide system for mental health and substance abuse treatment. We have hundreds of treatment professionals across the state, and are probably the largest provider of mental health substance abuse services within the state. I would like to, Representative Halverson asked about peer specialists. Actually, there is some language, not through the board, there's language actually in the Medicaid standards and through the state contracts, which actually allow for peer specialists to have certain standards and actually quite extensive training for those folks. So there are mechanisms to be able to do that without needing the licensure board to add a new a rule or the legislature to do anything different. We already have the mechanisms for it. I would like to address the idea of what this particular draft bill does, which reintroduces the certified mental health worker. And when I was originally, I've been in Wyoming working for 26 years in this system. And Chairman Barlow's answer was exactly right. We had some folks who were working for us that had bachelor's degree that there was no way for them to come in and continue working. So that came in and basically sunsetted them. And if they could get in at that level, then they could get in. And moving forward, we were going to require higher level of services. What this does is open that avenue for the certified mental health worker again, which is good. And we're in support of that. I will address with more specific comments the coming amendment. What we're not in support of is just experience. And I would like to more specifically address Co-Chairman Scott and saying the field has changed and the field is different. Historically, people with just experience were seen as just as qualified. This is a health treatment. And what other health treatment would we say if you're in a dentist's office and somebody worked at a dentist's office for 2,000 hours, they're all at once can be certified to work independently? As an attorney, somebody who works at an attorney's office for 2,000 hours, they're qualified to do that. People do have unique experiences, but it's not just in substance abuse. People have unique experiences with depression. People have unique experiences with family members with psychosis, with substance abuse issues. But when we start saying this certain group can be owned, we can just bring those folks in because they've had that experience, where does that end? Because you could say that for depression. Well, let's just bring people in that have depression, and if they've had that experience, they're qualified. what I really want to impress upon people is education is not a small thing. This is a profession. And what this is not about, and I know there's been some concerns on the committee's part, is speaking against things is like trying to not let people come into the state to protect, what we're doing. That's not what it's about at all. We have a ton of openings. These particular rule changes will do nothing for the outpatient mental health and substance abuse systems. And the reason it'll do nothing is I'm not just a provider providing in an institution where all I got to care about is this one payer. I have to care about all payers. And so these kind of changes, I think, can open up some venues. But as far as changing the system and like it would open up a big, a bunch of people that are held up, just is not the case. We surveyed all of our members. Nobody has people being held up because of issues with the licensure board right now. And I myself am in desperate need of somebody for Newcastle. But I'm not in favor of watering things down and just bringing people in that have nothing but experience. So as far as the community or certified mental health worker, I think it could be a good venue for group homes and for some other things. People absolutely should be working under supervision, because when you say experience, I don't even know what that means. At least these other things gives us a standard of care. So with that, just on this, we're supportive of it.
Thank you. Any questions for Mr. Demple? Question, Representative Sweeney.
Mr. Chairman, thank you. Is Gateway Foundation a member of your organization? The NASAC is, or
Mr.
not
Demple.
NASAC, but WISAC.
Mr. Chairman, Representative Sweeney, no, they are not.
So, Mr. Chairman, follow
up.
So they necessarily weren't surveyed because they aren't a member.
But he specifically said that they surveyed their members. So by virtue, yes.
Mr. Chairman, I'd like to clarify, they were actually offered to come in and declined.
Okay. Thank you.
Thank you. Further questions for Mr. Demple? Further questions? Oh, sorry, Representative Clem.
Thank you, Mr. Chairman. Mr. Demple, thank you for that. And I agree. I don't think. I mean, I'm seeing both swings of the pendulum here, one extreme to the other. And what I'm hearing you say is that we don't want to allow people to be certified or to practice in the state based on experience alone. I agree. I also don't want to put such a premium on education and think that that's you have to have education and that's the end all be all. And if you don't have the education, then you're out. And I think the compromise is somewhere in the middle, and I'm still not sensing it. I'm still not getting it. And I think it's to the detriment of the state. And that's the frustration that I have, is clearly there's a need. Clearly, I mean, there's a need for your profession within the state. There's clearly a need in the workforce right now that we don't have. And it seems like there's arbitrary roadblocks, and it frustrates me to no end because it's arbitrary. Because we have both swings of the pendulum here. Well, let's just emphasize, experience. No, that's not the solution. But neither is going to the other extreme and saying that you have to have a master's degree for something in particular. And so, I mean, that's what I'm trying to get at is where is the middle ground? And I'm not sensing it from anybody here. I'm frustrated. Help me out.
Mr. Chairman.
Mr. Demple, go ahead.
Mr. Chairman, Representative Clem, I totally understand. And I understand that the idea of we want to build our workforce. And what I'm trying to say is that within the workforce as a whole, beyond one company, it's not, a lot of these things are not driven by us. A lot of these things are driven by all of our payers. The insurance companies, the Medicaid, there's all kinds of rules we have to meet. And so if we went to, let's just say we did go to an extreme, we said, if somebody just have X amount of experience, they can be certified and do whatever. It doesn't help. The other end of the pendulum is you have to have this specific degree with all of these exact specific courses, which I don't agree with either. And I think the changes in the reciprocity actually cleared all that up, because all they're saying is, look, if you have this, you can move forward. The idea of working out something, I think moving forward, if there's a need in that, I would say, rather than trying to move something forward that's coming from one specific instance and one specific company, what if we go back and have a real discussion about that makes some sense with all of the folks? Most of this has been done and is reactive to things being done not with involvement of people. So I'm 110% for that. And I think that's probably your frustration. If this discussion was brought to the group as a whole, as well as the Wyoming Counseling Association, which are a bunch of independent providers not related to us, they should be involved with this discussion too. That's not what has happened. So I think we could probably come up with something that meets the majority of everybody's needs if we did that, versus trying to push something through that has really been discussed in very narrow realm.
Go ahead, Dr. Heaton.
Chairman Barlow, Representative Clem, just to speak quickly to that level of reciprocity, we did comb through and do quite a bit of research, and in consulting with national associations, our feedback has been that this is one of the more progressive looks at reciprocity that anybody has set forth, and they are really interested in the feedback that we get and how other states may be able to adopt similar language, because it is vastly progressive.
All right, further discussion. I'll just, since we had a little bit of discussion about experiential qualifications versus educational, a lot of those qualifications are actually laid out in statute. So if you have frustrations with that, then it's not on the board, it's on this body to adjust that. And that's, it's black and white, baccalaureate degree, human resource. That's our rules. That's what they are responsible for upholding. So if we want to adjust those things, that's on us. We can get feedback, and we will get feedback through the public process, but we're responsible for those. All right, further questions? Anything else, Go ahead, Representative Sweeney.
Thank you, Mr. Chairman. To add quickly to that, the same is true with the provisional.
That is correct.
So, but I do have a question. My belief is in discussion of this, frankly, is we're not trying to water anything down. We're trying to provide access and a pathway. And I'm frustrated that's what my amendment tries to do. And I take exception, hopefully, through these discussions. Hopefully we've opened a dialogue, not closed a dialogue, between the state organization, and hopefully the board won't act. You mentioned, Paul, that it's all reflective around one organization, one company. While I can understand that, I hope the board in the future certainly won't act punitively against that company for simply bringing forward issues to my attention, which a constituent started all of this over 2 years ago, discussion. So I bring forward information because of a constituent concern, not necessarily on Gateway's behalf, but Gateway has definitely helped me better understand the issues. You were invited and participated, both of you, to our task force meeting. So, so anyway, I just wanted to clarify that, Mr. Chairman. It necessarily isn't a question. So
thank you. Further questions? All right, thank you, Go ahead, Mr. Demple, if you want to.
Mr. Chairman,
final comment.
I don't think that Representative Sweeney meant this, but I I just want to be clear, I'm not on the board. Right? Yeah. Okay. Okay.
But you're on what?
Yes.
All right. Thank you very much. Thank you for your time. Anyone else want to provide comment to this bill draft? To this bill draft? Going once? Come on down. Welcome. Please introduce yourself and provide your foot to our wearying process.
Don't you see a problem?
Go ahead.
Mr. Chairman, my name is Mary Hosworth, and I am an employee with Gateway. I am the one and only in the state who is a clinical supervisor, so it has been pretty difficult, as Mr. Craig had mentioned. I just wanted to step up and say a couple things. First off, I really appreciate this opportunity, but also with the board, because as what was just mentioned, there hasn't been good discussion on this. And I believe that with Representative Sweeney and also Gateway, we have been able to bring this forward so that it can be looked at and discussed. We don't feel like it is just affecting us alone, but of course the whole addictions counseling aspect across the state, but not only the state, but also in other states as well, nationally. It's an issue. So I also want to touch on the watering down statement. We, as in Gateway, in this whole process have never asked for recognition for someone to be a counselor for just experience. That has never been stated anywhere. And I hear that, and I've heard that more than once, even in other realms, and that's confusing. Maybe after today, it'll be better understood that we'll be heard that it isn't about experience only. Education is just as important, and I believe Representative Clem, you made a good point about that. Education, we want people educated, but we also believe experience as well. There's examples, even Mr. Craig, who has an LCDC, right, and he explained that to you, based in Texas. He cannot be licensed in this state. He maintains his license through Texas. He has 20 years of experience, but that doesn't count. All right. And he has a license active in Texas. In the state, he doesn't qualify for a licensure. He doesn't qualify except even for the cap, because he would have to take more education in order to meet the requirements that are set out through statute in the rules. Now, 20 years experience isn't going to cut it. I don't know. So yes, education, extremely important. However, experience also plays a part. And I think trying to find that middle ground is very important. And I think we've started looking at that, I really believe, with the board. Again, getting it out and more clarified, because it sounds like legislative action, right, may need to be done because of language or because of some stipulations. They are acting on just what they can. So this is a good opportunity, again, to educate and help us to be able to move forward so that we can have a bridge, you know, with education and experience, so that we can better bolster the addictions counseling. And again, that's the only area that I'm speaking to. Now, I'm an LPC. I've done mental health work, and I am currently, of course, doing addictions. I appreciate the fact that this is a profession, and I absolutely don't want people who are not qualified to be out there serving our public, right? They need to be qualified. So if we could just take a step back, even some of the comments I've heard are based on historical feud or divide between mental health and addictions. We need to step back from that, be more proactive, and really think the bigger picture and see what can we do to better serve our clients. This is not just about one or the other, but what is best for our public. And you know, in all the ethical standards, whether it's ACA, NADAC, right, that it is to cause no harm. So the lack of qualified counselors causes harm, all right? So we just want to open up the doors to be able to really be realistic as far as who is qualified or not qualified, and keeping those high standards as well at the same time. We, as it was mentioned, we're in an institution. That's right. We're in the prison system. And the thing is, though, we still are CARF certified. We still have to follow all the ethical standards. We still have to maintain the quality of services for our stakeholders, which is the state of Wyoming, right? State of Wyoming, the board, okay, Department of Corrections, we have stakeholders. We are CARF certified, so we have to maintain those standards as well. So yes, do we not bill? Okay, the billing aspect of how to bill and who to bill and what to bill, that's over here, but we still meet the same exact standards and qualifications that are required by all providers across the state. These are things that are important to remember. It is not just about Gateway. This is about our communities and our clients. How can we better serve them? How can we better provide those quality services to meet all standards in the best way possible? So.
Thank you, ma'am. Would you say your last name again?
Hosworth.
Hosworth.
Hauswirth.
Thank you. Sorry.
Thank you.
Any questions for Ms. Hosworth? Any questions for Ms. Hosworth? Very good. I appreciate your testimony. Thank you very much. Anyone else like to provide testimony on this bill? Anybody else on this bill? Going once? Going twice? All right, we'll move on to consideration of the bill.
Mr. Chairman, move the bill.
There's a motion to advance the bill as a committee bill. Is there a second? Second, Clem. All right, committee, we're just going to, and you folks are not obligated to stay there if you want to step back. If we have a question, oh, there's an amendment we may ask you to speak to. So that's probably actually accurate. Stay there. It will be a little out of practice for us to ask you to comment in the middle of a bill consideration, but because there's a substantive amendment, oh, it's not out of practice. We do it all the time. That's what the good senator's saying. So we're going to start with the bill, work the bill. We can start at the beginning and go to the end. Page 1. Mr. Senator Scott.
Mr. Chairman, I just want to add one item to the title on page 1, line 3, after licensure, insert defining qualifications to practice as a certified addictions practitioner. That section is being modified later in there, and this would give us the license to do some things to make that modification work if we needed to.
Okay, I guess what I'm going to suggest, Senator Scott, is that that'll be just part of a successful amendment that occurs later on, and we don't amend it in two different places. We amend it now here and don't pass the amendment later, then we got to go back and strike this.
Okay.
Unless you want it there anyway.
I want it there anyway.
Okay, all right.
Just in case we have to do something else.
Okay, there's an amendment to, this is in the paragraph, the act relating bill, act part. Is there a second?
Second.
Second, Clem. Discussion? Would you just repeat the language?
Okay. Page 1, line 3, after licensure, semicolon, insert defining qualifications to practice as a certified addictions practitioner, semicolon.
Any discussion? Everybody understand the amendment? Any discussion on the amendment? Discussion on the amendment? All those in favor signify by saying aye.
Aye.
Those opposed, no. Motion carries. Any further amendments, page 1? Further amendment, page 1?
Thank you, Mr. Chairman. This could technically be page 1 or page 2. I'm going to make an amendment to allow, or I would invite LSO to draft the proper language to allow a criminal background check.
Okay.
And just to make this brief, because I don't want to drag it out, but anyway, going through the prior statutes, it looks like the majority of the other health professionals are all subject to a background check. And if you look at the title of Chapter 38, and this is 33-38, it's professional counselors, marriage and family therapists, social workers, and chemical dependency specialists. So this is not, this particular statute is fairly broad, covers a lot of people, and a lot of people who are dealing with individuals who are in a vulnerable situation, people who may be dealing with our children in a one-on-one situation. Certainly, if they were working in the school system, they would be subject to a criminal background check. So I think that in order to be consistent with the other portions of the statutes that we have, also as a public safety consideration and protecting our constituents, I think it's entirely appropriate for these individuals to be subject to a criminal background check. It is not an onerous situation. It would not be exclusionary in any way, shape, or form. It would simply be offering the licensing board to have that information, and that's important information for us to have. And as I mentioned earlier in our prior discussion, the medical board got caught in a catch-22 situation, which people were severely hurt, and we don't want that to happen. So I would offer that and offer to, if the motion passes, that LSO properly drafted and put it in the proper situation or proper place in the statute.
Second.
There's a motion and a second, a well-explained motion and a second.
Mr. Chairman, I would also ask the LSO be instructed to modify the title as necessary to make sure that we're accommodating, because we're amending basically all these statutes in something going beyond education here. The reason, Mr. Chairman, I seconded it was my previous objection been that we had been totally backed up. If that's cured, then this is a good idea.
Follow-up discussion, Representative Halverson. There's a motion and a second to add criminal background check with the appropriate language. We're giving license to the LSO to come up with that. Representative Halverson.
Thank you, Mr. Chairman. And to add to the good co-chairman's comment, I would flip that. I would not make this dependent on DCI catching up. I would use this to get DCI to do whatever it can do to meet the needs of various providers in this state who are suffering with the slow response of background checks.
Representative Halverson, are you adding an appropriation to this bill?
No.
Thank you. Further discussion, Senator Scott.
Further on the amendment, when we did the bill last session, the committee bill that loosened up the requirements for how you treated a criminal one, we were very careful in this area to retain some language so that a prior conviction would not necessarily disqualify somebody from practicing, because we felt there was some potential value for using somebody that had the experience and become reformed in this area. So, Mr. Chairman, that language is already in the statute, and you'll see it reproduced in part in this bill.
Okay, thank you. Further discussion on the amendment? Further discussion on the amendment? All those in favor of the amendment, please signify by saying aye. Aye. Those opposed, no. Amendment is adopted. Thank you, Representative McGuire. So we are, I guess, between page 1 and page 2. Now we're on page 2. Any amendments for page 2? Amendments for page 3?
Mr. Chairman.
Representative Sweeney.
Mr. Chairman, LSO passed out an amendment which starts at the top of page 3.
So I just want to be clear for the committee that has this in the audience that had this is actually maybe a delete and insert type of an amendment, creating a new section, subsection 3, and then some subsequent language. So go ahead, Representative Sweeney, and explain your amendment. You're making a motion to accept this amendment, so go ahead.
Yes, I'd make a motion in.
There's a motion and a second. Halverson is a second. So go ahead and explain your amendment.
So what we're attempting to do here is not water anything down, but at least recognizing some hours of supervised work experience, which currently does not appear in state statute. So we're trying to add some language. And then down at the bottom of that, which this is some inserts, and then you go back to from 3 down to Romanet, back on the bill on page 3 of what was passed out to 4, 5, and the existing 6, and then 7 would be inserted, Romanet 7, which would, I mean, this will all get renumbered page-wise, but notwithstanding paragraphs Romanet 3 and Romanet 6 of this subsection, a person who has received a bachelor's degree in mental health discipline other than a degree in addictions therapy may be granted full certification under this section after providing to the board satisfactory proof of completion of 2,000 hours supervised work experience. And so our attempt here is to, besides the bachelor's, to bring in some understanding of supervised hours.
Okay, that's an explanation from the bringer. Any questions on the amendment? Committee, questions on the amendment? Senator Scott.
Mr. Chairman, I think based on some of the previous testimony that whether we pass the amendment or not, whichever type of degree when we get to session, we're going to need to define what that means and use as a very minimum at least the language that the board is using in its regulations, and then see if it ought to be broadened. But I think we probably need to define that, Mr. Chairman.
So what Senator Scott is referring to is the human behavioral versus the current language is human resource versus the language that the board suggested, which is mental health. So
whichever one we use, I think we're going to need to define it during session.
All right, thank you.
Yes.
Representative Sweeney.
Just, I'm not good at this stuff, so asking for some advice. Would we be better off changing now? I'm not comfortable going with human resource, but if we change that from human behavioral at the very beginning to mental health, would that be better?
Senator Scott. Mr. Chairman, my opinion on that is it doesn't make any difference. Whatever language you want to use, I think we need to define it, and I think the definition needs to be at least include all the things that the board currently has in its proposed regulations, and then we can discuss, but whichever sounds better to you.
Okay. Further discussion on the amendment. Discussion. So we're going to get a little bit out of order because I want some input from the board since they're responsible for actually implementing this should it become law. So I'm going to give them take a little latitude here and get some input from them. Dr. Heenan.
Yes, thank you, Chairman Barlow. In reading the amendment, we just had a few questions. So under the initial paragraph on the top, little I guess, it says that the certified addictions professional assistant with not less than 2,000 hours of supervised work experience. We just are curious, how would they define that 2,000 hours of supervised work experience? What would that consist of? And then we also wanted to just point out, like, delineating that specifically for CAP does create somewhat of an inconsistency, as we don't have that in any other license or certification where we would be offering that same level with regards to experience.
Okay. Thank you. Further questions?
Yes.
You're directing a question to Ms. Heenan. Okay, through me to Ms. Heenan.
Chairman, to the board. Doesn't social workers for an LCSW have a 3,000 hour requirement to be certified?
Ms. Heenan.
A licensed social worker has 3,000 hours, yes.
So clearly this is a
certified.
certified. The licensed also has an educational requirement. What we're talking about here is giving an option of education or experiential. That is not, and what her point is that is not allowed in any other licensure or certification. Please continue.
270 hours, 70 hours, 200 hours.
Right here.
But-
How do they define it?
So let's be clear. So go ahead, Representative Halverson.
I would ask you, how do you define hours of coursework or training or training? I assume that Representative Sweeney, and I probably shouldn't assume, means the same thing that your rules do.
Go ahead.
Chairman
Dr. Heenan.
Barlow and Representative Halverson, with regards to each specific discipline, we differentiate between indirect hours and direct client contact hours, and then this just says 2,000 hours of supervised.
Further discussion? Further discussion? All right. Further discussion on the amendment. Further discussion on the amendment.
Chairman Barlow, we also
Right.
had another question under section 7, where it says, who has received a baccalaureate degree in a mental health discipline other than a degree in addictions therapy. We are just clarifying, does this mean if they have a bachelor's degree but no coursework in addictions, would that qualify?
So the bringer of the amendment, I think that you want to clarify that.
I'm not here to write the rules. I think after the statutes, if the amendment goes through, this was hopefully to bring forward some issues through statute that, in my opinion, the board hasn't been very open to change. So, but I'm not prepared to define things for you here today.
Okay, further, so we're back on the amendment. We're not going to interact with the board unless there's a question we want clarification for. So we're back on the amendment. This is general discussion on the amendment as provided. Go ahead.
Mr. Chair,
Senator Bouchard.
Mr. Chair, I just wanted to restate the question. Maybe we could, but if you don't.
General discussion on the amendment, if
Okay.
you want to have general discussion on the amendment or amendments to the amendment. Go ahead.
Thank you, Mr. Chairman. And yeah, I'm thinking perhaps an amendment to the amendment would be in order here. So just looking here where it says kind of in the middle of the bulk where it says, or the applicant holds in good standing a current certification as certified addictions professional assistant with not less than 2,000 hours of supervised work experienced as and the new language or my amendment to the amendment would be as defined by the board. I think that gives you some latitude there to define that. So that would be my amendment as defined by the board after experience. I'm making that motion.
There's a motion to insert as defined by the board, and there was a, was there a second? Okay, second. I thought I heard something, but there's a second. There's a second. So we're on the amendment now, to the amendment, and it would insert as defined by the board after the word experience and before and. Is that correct? Right. Does everybody understand the amendment? Does everybody understand the amendment? So the amendment is to, I believe, define what the 2,000 hours of supervised work experience is. All right, discussion on the amendment to the amendment. Representative Sweeney.
Thank you. Would the bringer of the amendment to the amendment be willing, the national organization, if we could insert SAMHSA, Substance Abuse and Mental Health Services Administration, actually has that, which the board could utilize.
Further discussion on the amendment. Further discussion on the amendment. Representative Clem.
Mr. Chairman, thank you. You directed that toward me. I'm not exactly sure what you mean. Are you saying that is it SAMHSA or SAMHSA actually defines what those 2,000 hours are? Is that what you're implying? I guess that's what I'm trying to figure out.
Mr. Chairman, Representative Clem, the scope of practice, yes.
Okay, thank you. Further discussion on the amendment. Senator Scott.
As I read the amendment, with the amendment to it or without it, the board is constrained to use professional training experience standards of the appropriate national professional organizations. What I'm going to ask is to bring the amendment to the amendment is, should we add to that or the standards of an appropriate federal agency, which would bring in your SAMHSA standards is something they could use.
Representative Clem.
Mr. Chairman, in response, I'm fine with something like that. I think that would be okay.
Mr. Chairman, let me bring that as a second.
Okay, let's deal with that separately. So right now we have a amendment. Any further discussion on the amendment to the amendment? All those in favor of the amendment to the amendment signify by saying aye.
Aye.
Those opposed, no. Motion carries.
Mr. Chairman.
Okay, so now we have a new paragraph 3, and if we are going to amend, and a new paragraph 7 within this section of the bill. So if we're going to amend within those two, we're going to have to work off the draft proposed, or no, we don't have new. We have an amended amendment. So now we're back on the amendment. Senator Scott.
Mr. Chairman, back on the amendment, I would, on the last line in the paragraph 3 as shown in the amendment, I would make a motion that we amend that by adding the words or the appropriate standards of an appropriate federal agency. So give the board more latitude as to where it can get guidance from.
Mr. Chairman.
Go ahead, Representative Sweeney.
Before I second that, did the bringer of the amendment to the amendment mean instead of federal, nationally recognized, like, because the Substance Abuse and Mental Health Services Administration, I don't know if that's
part of the Department of Health and Human
Senator
Services.
Scott.
Okay, Chairman. Thank you. Okay. Second.
So there's a second to the motion. Any discussion on the motion? Restate the motion so that people know what they will be voting on.
After associations on the last line of the new of paragraph 3, or the standards of an appropriate federal agency.
Everybody understand the amendment? Any discussion on the amendment? All those in favor of the amendment signify by saying aye.
Aye.
Those opposed, no. No. Right, amendment is adopted. We're back on the amendment. The amendment is adopted. We're back on the amendment. Any further amendments to this? Any further discussion on this amendment? Senator Peterson.
Thank you, Mr. Chairman. This whole conversation, and particularly this amendment, I won't call it watering it down, but I will call it relaxing the requirements. And that's just what we're doing here. And I'm still remain unconvinced that there's a need to relax these requirements. My 13 years down here in the Senate, and my first assignment was through for a mental health and substance abuse select committee. And then I was put on labor and health. And so I've had extensive experience in working with mental health providers around the state and different problems that we've tried to work through. What I've noticed today is perhaps a problem from one of our providers that we depend on. And by the way, thanks to Gateway for the services they provide, it's critical for our state. And so we appreciate that, but it sure would be a lot easier. It would be my strong recommendation, working through the experiences that I've worked through the last 13 years, that if everybody would get on the same page. I don't know why they don't belong to the association, WAMSAC. They should. I don't know why third parties, independents out there, don't belong to WAMSAC. They should. But this splintering and this approach to this so-called problem or concern concerns me a great deal. And I don't disagree with the process, because you have every right not to belong to an association and bring your concerns through a representative or a senator or that. I understand that. That's the way the process works. But the pep talk of getting on one page and addressing these problems and concerns, I agree. And what I'm saying is they could be resolved through this association. There's just no excuse for it. I would love to see the day when an association of providers throughout the state would come, whether unified or not on their position, would come with one position to this legislature and trying to address a situation or a problem. It would sure solve a lot of concerns and problems that we're having to deal with. So in the long run, I still remain unconvinced that there is a need out there for this. The whole time, Mr. Chairman, during this conversation, I was likening it to, let's say, education in Wyoming. That's been on my mind lately. Education in Wyoming. If this same conversation were being held in this discussion, this debate, were being held about education and relaxing the standards of our teachers. So a teacher with a business degree with substitution certificate has 2,000 hours of substitution in schools, now becomes a fully certified teacher. I don't think education would stand for that. It would be a very short debate. And yet here we are in mental health services talking about providers, professional health counselors dealing with people, patients, clients. And we're just going to say experience counts, and it does. But so does education. So I would be a no vote against this. I agree that it might be a good compromise. That's fine. I don't agree with the way it was brought. Again, if it was, the other side needs to do some work. And I say that to the association, the WAMSAC folks. I say that to the independents. I say that to Gateway. I say that to everybody that we contract with as a state. You need to do some work. And becoming unified, if we're going to address these problems, get on the same page. It sure would help if everybody's on the same page to begin with. And that's all I'll say, Mr. Chairman.
So we're currently on the page of consideration of the amendment and the amended amendment. Senator Scott. Thank you.
Mr. Chairman, I don't think this is the final word on this. I do think we need to pay attention to the problems that are experienced by a provider that has been demonstrably doing good work in our institutions, correctional institutions, with results that unfortunately we learned about the hard way when we cut back and our recidivism rate went up. So I think we have to respect that. I am convinced from the comments from the Northern Wyoming Mental Health Center that Mr. Dimple, I greatly respect that there's a need for some education requirements in here too. And I think those need to be worked out as to something that is available to the working people that are working in our institutions as a practical matter. So I don't think we can deal with that right now. So I urge adopting this amendment, but being open as we go through to a further compromise. I think this amendment is a good compromise, but I think it probably will need to go a step further before we're done. So I urge adopting that.
Okay. Committee, further discussion on the amendment. Further discussion on the amendment. All those in favor of the amendment signify by saying aye.
Aye.
Those opposed, no.
No.
No. Right. The amendment is adopted. So we're continuing on through the bill. So anything further on page 3? Page 4, page 5, page 6, page 7, page 8, 9, 10, 11, page 12.
Mr. Chairman,
Representative Sweeney.
I would just back on page 9. Did Senator Scott intend to do anything today?
Mr. Chairman, Mr. Dimple talked me out of it.
Yeah, thank you, Mr. Chairman.
All right. We're on page 12, page 13.
Mr. Chairman.
Senator Scott.
One question there. The applicant has received, on looking on lines 17, 18, applicant has received a baccalaureate degree from mental health discipline. Now, my question is, should we also allow for the possibility of a master's degree, or is that a circumstance that will not arise? Could somebody get a master's degree that wouldn't qualify for your more advanced licensure, but say they had gotten a bachelor's degree in some totally unrelated field, English literature, for example, and then got a master's degree in a mental health related discipline? Could they possibly come in for this and be disqualified because their degree was too advanced, or would they always be likely to come in for a more advanced licensure?
We're gonna go to the board if they want to respond to that question. Just go ahead, please.
Thank you, Representative Barlow. Senator Scott. This is a bit of a baby of mine, a long held hope that we could get this. So I'm going to volunteer to jump in and answer questions related to this specific section. I think really as it's written, the intent is really to focus on the baccalaureate in mental health discipline. If a person had a business bachelor's and a master's in counseling or a master's in marriage and family, it would be appropriate for them to apply for the master's level, not the CMHW, the certified mental health worker. They would apply at the highest education level that they've attained that qualifies within our rules.
Senator Scott. All right. Thank you. Thank you very much. Anything further on page 12, 13, 14,
Mr.
Representative
Chairman.
Sweeney.
Thank you, Mr. Chairman. On page 14.
Page 14.
Is, I would, on the back of what was handed out, relates to, is a second amendment as it relates to page 14 in on line 16, we would insert that language. And I would ask, make a motion to provide this amendment.
All right, so there's a motion to, does everybody have the language that Representative Sweeney is talking about? Okay. You folks have it as well. Hold on, we don't have a motion yet, and I will come to you. So there's a motion to accept to entertain this amendment. Second. There's a second for Representative Clem. All right, first I'm going to get a little feedback from the board, and then we're going to discuss it within the committee. Okay. So go ahead, Ms. Heenan, Dr. Heenan.
Yes, thank you, Chairman Barlow. I just wanted to point out that the rest of the amendment brought forth by Representative Sweeney is specific to the CAP, which is the Certified Addiction Professional. In this section, if you make an amendment down below, you're making an amendment to all licensure and all certifications on the board, not just that CAP that you've been discussing earlier.
Okay, thank you.
Mr. Chairman.
Ms. Heenan, actually, I'm going to suggest that that amendment does refer to 106C, and 106C is specific to the CAP. So I'm not sure, maybe there's a misunderstanding, and I'll read the amendment more closely, but it does make a reference to statute, and that statutory reference is to a CAP. So maybe look at that in context, and maybe we'll circle back. But what was your intent, Representative Sweeney?
It was intended as to reciprocity for all, not just CAP, licensure, and to deal with the reciprocity issues.
All right, further discussion on the amendment. There was a motion and a second. We're on the amendment before you, reciprocity.
So, Mr. Chairman.
Representative Sweeney.
A couple of things up above where it being the board in rules has eliminated the substantially similar, which they answered that question earlier. I also would like to look at striking under reciprocity substantially similar as listed both in A and B, which I had not.
So this is an amendment to your amendment?
Yes.
Okay.
And
let's, so I want everybody to be clear. In 108A and 108B, there are in the fifth line of each one, there is licensure requirements substantially similar to. And your amendment is to strike substantially similar. Is that correct?
That is correct.
From both parts. Is there a second to that motion? Does everybody understand the motion? Is there a second? Second, Scott? So, Bouchard, my apologies. So now we're on amendment to the amendment. Discussion on the amendment to the amendment. Substantially similar. Representative Sweeney, if you'd like to make comments on why you're suggesting that?
Being in all the way through in every chapter on reciprocity, the board had taken the time to actually review that language. And so this, I had not caught that, and this would, in my mind, bring it into what they were trying to accomplish. So I didn't want to be more restrictive.
Since this is seems to be intended to match some actions of the board may be considering, I will allow the board to make some comment on this amendment to the amendment.
Chairman Barlow, Representative Sweeney, I think we're okay with the striking of the substantially similar.
Mr. Searles.
Representative Barlow, Representative Sweeney, I would probably ask the LSO examine the rest of that 108 because I believe that substantially similar will be listed in many other places throughout that chapter for the other types of licensure. And if we're going to strike it for these two, probably should strike it for all of them if that's the wish of the committee.
I looked at it pretty quickly, and there's only an A, B, and C in 108. So this is striking C and adding D, so there's nothing else to look at, Mr. Searles, just for that, in the context of that. So, so there's amendment to the amendment on the floor to strike substantially similar. We're going to give our LSO just a moment.
Mr. Chairman.
Okay, they're out of their moments. Go ahead.
We would, if that's the committee's wish to strike substantially similar, you might also consider striking the words under the laws of another state having licensure requirements substantially similar to those required by this act, may, comma, or leave the comma.
So what we're basically saying is that we're not going to worry about the comparative at all with that potential. Anybody have any, restate the striking again, please, Chris, Mr. Land.
Subsection A, I think it's line 4, under the laws of another state having licensure requirements substantially similar to those required by this act, may. May too.
I think that's going too far. Go ahead, Senator Scott.
Mr. Chairman, I think whether or not we pass this one, and maybe it would be useful to pass it, but I think we're going to need to take a careful look in the first committee. That's the trouble with having a bill that we don't carry over to another time because there isn't one. But in session, I would think we'd need to have a careful look to make sure we aren't, I think they had a satisfactory solution to the rules, and I don't want to inadvertently mess with that.
Okay. Further discussion on the amendment to the amendment. Further discussion. Representative Clem.
Thank you, Mr. Chairman. I'm not sure that this has the desired effect. In the way that I'm reading it, the substantially similar there gives a little bit of wiggle room by striking substantially similar. What you're, at least my understanding of what you're doing here is saying that that in order to grant reciprocity, then you have to meet the requirements of this state. That it can't be, it doesn't have to be similar to or substantially similar to. There's not the wiggle room. You take it away, and you're saying that in order for South Dakota, someone licensed in South Dakota to come over here, they have to meet all the requirements as demanded in our act. And so if they don't, they can't be licensed. I think it has the counter effect of what the bringer is trying to bring here. So I'm probably going to be voting no on this.
On the amendment to the amendment. On the amendment to the amendment. Senator Bouchard.
Yeah, thank you, Mr. Chairman. Yeah, I think one of the reasons why this is worth discussion is because the problem has been when we look at the similarities, who gets to decide? And so I think, as Senator Scott has said, it certainly is something that maybe a placeholder that we can talk about in the future. I don't think it's an up or down to the whole thing here either way. But remember, that is some of the problem that we've been having is deciding what Missouri does or what Texas does, and quite frankly, some of these states have been advanced as comparative to Wyoming. So but it seems like we're being held up on what they taught in school or what they've decided was a degree there, as opposed to what we have decided was a degree. So that's I would. I don't think it hurts either way. I mean, I probably will vote for it. I did second it.
So there is a amendment before us to strike substantially similar, and I would respectfully say I'm going to vote against it because then we don't have a sentence anymore, because I don't think we have a verb in the sentence, but I'm not sure. But I'm not a English teacher, but I don't even, yeah, so.
Mr. Chairman.
Go ahead.
would it be, if the second is so inclined, I would withdraw the amendment.
Second. Amendment's been withdrawn. So we're back on the amendment. Back on the amendment. So in its entirety, the amendment. Further discussion on the amendment? Further discussion on the amendment?
We're back on the amendment.
We're back on the amendment.
Okay.
The reciprocity 108.
Mr. Chairman,
Ben
on
Sweeney.
D, on the amendment, I'm looking for clarification. Should we take out WS 33-38-106C? Is that a limiting factor only to cap?
Well, I think if that's an open question, I think we have actually two things going on there, because on the third line, there's an or. And the first thing, they were talking about the national examination approved by the board, and that would be for all licensures and certifications. And I think that goes to Dr. Heenan's. The second part of it is more specifically to the cap, and that has to do with the degree requirements. So actually we're talking, there's two different topics in this. One is a certification or an examination requirement. The second one is, and that's for everything, licensure and certification. The second half after the or is related just to caps, and it has to do with the, God, I can't even see it now, degree issue. So there's actually two issues. One is broad and one is very constrained within cap. So anyway, that's my understanding of this amendment. If that's your intent, I respect that. We'll move forward. But go ahead, Representative Sweeney.
Thank you, Mr. Chairman. My intent was to be broad.
Okay. All right. Representative Clem.
Thank you, Mr. Chairman. If the intent is to be broad, then I'm going to amend this amendment. And on subsection D, on the third line, it's or. It's the second to the last word there. So, or who has not received a degree that satisfies the requirements of WS in a cited statute, to strike that. So striking or who has not received a degree that satisfies the requirement of what Wyoming Statute 33, etc.
Second.
So I want to be clear that the amendment to the amendment is to strike everything from including the word or through the rest of the section? Or where are we stopping at?
Mr. Chairman, we're starting at the word or and ending at 3338-106C.
Thank you for the clarification. The second understands the amendment to the amendment?
Yes, Mr. Chairman.
I guess now what we're saying is if they haven't successfully completed an examination, now they're going to be required to satisfy those requirements. So I'm not sure what we're getting out of this now. I'm just trying to be reading it as plain language, and I'm not sure what we get. What we get. So, all right, amendment to the amendment. Amendment's amendment. There was a motion and a second. Amendment to the amendment. Strike or through parentheses C parenthesis. Any discussion? All those in favor signify by saying aye. Aye. Those opposed, no.
No.
The motion fails. Back on the amendment as in total. Back on the amendment. Further discussion on the amendment? Further discussion on the amendment? All those in favor of the amendment as presented, please signify by saying aye.
Aye.
Those opposed, no. 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 I need all the ayes to raise their hand. 2, 4, 6, 7. Noes? Seven. Fails. Motion failed. I'm sorry. I keep looking. We got a couple extra people here, and I keep trying to count them and see hands, and I keep looking here and going, what is wrong with these people? Sorry. For those that weren't here yesterday, those Senator Pappas and Representative Wilson will be members of this committee next, and Representative Yin, who is in the audience. All right. Further discussion. Any other amendments on page 14? Amendments on page 14. Further amendments to the bill. General discussion on the bill. General discussion on the amended bill. Discussion on the amended bill.
Mr. Chairman.
Senator Scott.
Urge we introduce the bill. I think it is a good step forward. It doesn't solve all the problems, but I think it makes considerable progress and will be helpful to the board.
Okay, further discussion? Further discussion. Senator Bouchard.
You know, I thank you, Mr. Chairman. I just want to say that some of the work that we're trying to do here is we have a company that's servicing our prisons, and they're being fined because they cannot get work. They cannot get workers in there. So I'm disappointed that we didn't at least move forward with this amendment so we could try to fix some of that. So I hope we can do that in the future.
Okay, further discussion on the bill. Further discussion on the bill. Please call the roll.
Representative Clem.
Aye.
Representative Dayton. Representative Guru.
Aye.
Representative Hallinan.
Aye.
Representative Halverson.
Aye.
Representative McGuire. Representative Stivar.
Aye.
Representative Sweeney.
Aye.
Senator Baldwin. Senator Boner. Senator Bouchard.
Aye.
Senator Peterson.
Aye.
Chairman Scott.
Aye.
Chairman Barlow.
Aye.
13 ayes, 1 no, Mr. Chairman.
305 has been introduced as a committee bill. I'm pretty sure it's going to be a Senate file. All right, we've got a few minutes left in our agenda, and we had somebody going to come in and talk a little bit about some other mental health. Thank you to the board. Appreciate your time.
Mr. Chairman,
Go ahead.
thank you to the board. Truly appreciate all the board's hard work and the executive director. And this was not meant to be disrespectful. And we need to continue the process. Thank you, Mr. Chairman.
Thank you. And we do appreciate the hard work that's being done, not only by the board, but by our licensed professionals, certified professionals out in the state. So thank you.
Chairman and committee, thank you guys for your time today.
Thank you. All right, so this is not on the agenda, but this has come up in the last couple of weeks, and the co-chairs have visited about this. We're going to get a short presentation and update on some concerns that are coming out of a topic that we had in our last discussion, which was adolescent treatment. And come on up. Don't be shy. Shay, you can come up too, if you want. Mr. Joe Gallagher from Wyoming Behavioral Institute is here. We have some handouts that actually, let's provide those to. Oh yeah, if you want to pan them out, that'd be great. As some issues that they're concerned about and dealing with within the context of mental health and substance abuse. I have made sure the Department of Health and the Department of Education are aware of this. We also, as the committee will recall, that we discussed some of the adolescent components of our care system at our last meeting. And so this is kind of a follow-up that didn't make it on the agenda just due to timing of its receipt, not its potential not being worthy. So with that, I'm just going to turn over to Mr. Gallagher. You're going to get some minutes, not as many as we'd hoped, but some minutes to go to that, and then we'll take any other public comment. So go ahead, sir.
Thank you, Chairman. The reason why I wanted to come and
introduce yourself, please.
Oh, I'm sorry. Joe Gallagher. I'm the CEO at Wyoming Behavioral Institute. The reason why I wanted to come and speak today, Mr. Chairman, was the Department of Health and the Medicaid division have been working on the reimbursement structure for adolescent acute care moving forward in 2019. Under the current structure, since 2009, there's been a case rate associated with the acute care division and I'm just talking about children and adolescents. And Wyoming Behavioral Institute serves as the resource for the state for Medicaid recipients or for adolescents and children. It also serves as the state hospital safety net for adolescents and children. In 2009, there was a case rate set, and the rationale for how the case rate was set was based on costs associated with the delivery of that care. That case rate hasn't changed since 2009. But in 2019, we're looking at going to a different methodology for Medicaid reimbursement so that that case rate will actually go down by about $2,000. The concern that I've had with that, in addition to the rates for placement for patients in residential treatment, makes it challenging to be able to maintain the service. What I did for you is I tried to outline that in my letter. I tried to show you what other states have done for adolescent and children and for behavioral health, because it really is a specialty program, and we're the only ones really in the state that are providing that service. What most states have done is they've looked at a methodology where they look at the gap between what you would receive for Medicare and what you would get for a Medicaid, and they come up with a rate or a per diem. The challenge moving forward is that I think in Wyoming, we're challenged throughout the state with being able to provide care at a low cost, so that the methodology that we've used in Wyoming has often been the variance between your cost structure and Medicaid, not Medicare and Medicaid. And without complicating that issue, because Navigant is the group that works for the state to do those calculations, that actually would take quite a bit of time. But what's included in your cost varies too. And whether or not that actually covers your cost is always questionable. But the variance currently between adolescent and child reimbursement compared to adult reimbursement or other types of reimbursement throughout the state is already lower. And so what the question that will have to be answered, and I think I want to first of all say that the Department of Health, the Medicaid division have all worked actively and supportively, and I think if they had more money, they would support giving out more dollars. But when they look at the methodology, the costs don't necessarily support the variance. And so, however, for me, what I have to look at is whether or not the program can continue with it being underfunded. So I tried to explain that in what I presented to you. I tried to explain that other states have carved out behavioral health from the APDRG. They have not gone with that. They said it doesn't work. I've also shared with you from the Federal Register the proposal of the rule that was adopted that says that that doesn't work. And I've shared with you also some of the way that a rate would be calculated for Medicare. I'm not asking for additional dollars from this year. I'm just asking that the dollars don't go down. So, thank you. I don't know.
Okay, committee, question? Let me ask a couple then. I heard a rumor that you had closed an adolescent unit in WBI. Could you?
Yes, there were, the adolescent service was 34 beds, and that has been reduced to 20 beds.
So why did you do that?
We did that for two reasons. One reason was because we couldn't get any, one of the challenges also with the cost structure is there are also challenges with lengths of stay. And when you have a case rate versus a per diem rate. If the children stay for 30 days or if they stay for 10 days, that case rate remains the same. So part of what we also have tried to focus on is other types of services and step-down services, but there was also a great need for older adult services within the community. And so and those folks weren't being treated. So we have added a 14-bed older adult service or geriatric service.
Furthermore, I've heard that there's troubles in getting kids a placement after they've been through your institution. Step down to one that's a little less.
Yes, what's happened is that there have been several residential treatment facilities that children would normally go to after a period of time of acute stabilization. And because it's been difficult to remain competitive from Wyoming with other states, residential programs don't accept the Wyoming kids. They're accepting other folks who have a better rate, and they can do that.
Thank you, Mr. Chairman. And following up on that, because I have a little bit of background, having formerly managed a residential group home, part of that is in many of these don't get paid. So whether it's an RTC or a residential group home for someone who is recommended, if they go to a WBI or a PRTF and they step down or recommended to step down, unless they're involved with the legal system and the Department of Family Services, there's no way for them to get paid. So in other words, as a former manager of a group home, and if I get a call from WBI saying, hey, I've got a kid that's on Medicaid but not involved in the legal system and not involved with DFS, can you take the kid? I unfortunately have to turn them down 100% of the time because there's no mechanism for us to get paid, because at least private pay, we've stopped doing business private pay because we don't get paid. And therein lies the gap, is that many of our group homes and RTCs are unwilling to take these kids from PRTFs because they're not involved in the legal system because they don't get paid. So the gap is how do we make sure that we can take those kiddos who need those services and get paid at the same time? And there's not a solution. I don't know if you have any ideas on how to shore up that issue, but that's really where the issue lies. And what compounds this problem is that a lot of times when these kiddos are presenting with these problems, DFS doesn't want them on their rolls, and they're saying, well, send it, go to WBI or another PRTF, because they know at the end of the day they're not going to be paying for these services later on. It just compounds the problem. It's kind of vicious, actually. So I don't know if you have any thoughts on how to help with that.
I know that Dr. Nelson is behind me. He may have other thoughts on that, but I think that I believe that the first step is the higher acuity step down, which would be the PTRF. We're not maintaining a competitive wage with that, is what I'm hearing back from the providers. So they're not accepting it, because then when they step down from that level of care, there's not that sense of coordination of reimbursement, so that, again, they cycle back through the system. And that's going to continue to happen. And so my concern is that there's going to be more of that cycling coming through, and there's going to be less of a window to go through because the reimbursement is going to decrease even more.
Chairman Scott. Oh.
And therein lies the problem, is the cycling through. What happens is because we don't have this mechanism, what oftentimes happens is these kids go back home. There's no step down facility or anything like that. And they end up going home only to repeat the cycle again and costs more money in the long run, because we're talking about Medicaid dollars. So what happens is it actually costs us more in the long run by not doing anything, plus the heartache that it puts these families and these kids that they have to go through. That's the real, you talk about victims in this thing. That's the real victims in all of this. And so, I wish we could come up with a better solution, because we have the facilities, we have RTCs, we have group homes, we have PRTFs. It's a matter of how do they get utilized? And how do we make sure that the payment mechanisms are there so they can be utilized, so we're not paying more in the long run by this vicious cycle of going back to a PRTF, et cetera.
Representative Sweeney.
Thanks, Chairman Scott. So as an example, there's a difficulty on payment. And is it true that in the future, we're looking at another, even though you've had no rate increase through Medicaid and Department of Health, under your contract with the Department of Health through the state hospital for adolescent care, and now because of those rates, we've lost 14 beds. And in the future, do you have a feeling that there's going to be another 30% reduction on funding? And in comparison, rate-wise, does IMD, the Institute of Mental Health, and have anything to do with mental disease, have anything to do with this rate? And also, just curious, what's the rate at the state hospital per day in comparison?
The IMD issue first, just start with the IMD issue is the Institute of Mental Disease, and what they do with the IMD issue is they give states the opportunity to do demonstration projects where they try to get people out of emergency rooms and higher level of care was the thrust behind it, and they do a Medicaid match for that. We had made a recommendation at about 5 years ago to look at that to the Department of Health, but at that time they had decided that that wasn't an appropriate thing for them to look at. They are looking at it now. I actually talked to Director Forslund in the hallway, and he said that they are going to visit that because a new letter went out to the medical directors for Medicaid, or this week, actually on November 13th, that said that IMD issue is open up again. But that's really adult. That's more adult Medicaid. The state hospital, if the state hospital, their current costs, and I just had the opportunity to have a conversation with their interim CEO and CFO, the costs there are about $1,020 a day for adults, but they feel the cost would be higher for adolescent treatment, to answer your question. And the current rate for Medicaid for adolescent treatment at WBI is $540 a day.
With that, we're going to need to move on. I'm going to suggest to the committee that we've uncovered a problem here. Some of it appears to me to be just straight old-fashioned budget problem. We're starting to cut Medicaid back, maybe too far, maybe the cuts haven't been appropriately handled. That's something that members are going to need to look at, because we are going to have to vote. And I think some of the health department budget was only 1 year funded, so we're going to see some of that during session. I would say we've uncovered a hole in the process, listening to Representative Clem, and it's obviously too late for this committee to develop legislation for this time, but this would be a prime area if one of our members wanted to take it on and bring a private bill that would at least start to solve some of those problems. That would be quite useful. So we'll have to proceed on both those bases, and I think that we'll have to have some discussions during session. Is this an area? How do we want to handle this during the next interim? Because I think we have a series of problems in our whole mental health system. We're going to need to study it. So,
Mr. Chairman, to that point, I realize it's late in the game. However, would it be advisable that the committee chair could draft a letter to joint appropriations if the committee so decide, alerting them of the situation, and if there's some spare change, Because there's, there's
There's a 10%
a real,
operating deficit.
I think 500,000 to $1 million would go a long way to solving the problem temporarily until we can get this worked out with on the IMD. And these are the most vulnerable kids, and a lot of suicide. And we're really turning a blind eye. And so that's my only suggestion, Mr. Chairman.
And we hold that one to the end of the meeting and see if we want to do that. Anything further? Somebody else want to speak to this? No, do you want to add anything?
Chairman Scott, and Representative Sweeney, I really appreciate that. I think one of the concerns I have is, and it goes to Representative Clem as well, is that we're moving into crisis around this. That's what I want to share, and that there's not multiple facilities to provide the care. And I think other states, again, didn't include behavioral health in this APDIG methodology. And what I don't want to do is continue to ratchet down on beds. Because what happens with that, and what's happening, for example, today, there's about 9 adolescents waiting in either emergency rooms or critical access hospitals to get into the 20 beds that are available right now at WBI. And that becomes much more costly than anything else, and they're not receiving active treatment. But I really appreciate you having time for me today. Thank you.
Thank you. With that, committee, let's be back here at 1:15. If somebody in the health department could tell Director Forsland, we'll be 15 minutes late starting. We're adjourned.
Thank you.